Hello, 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 hello.
I welcome you all on behalf of the organizing committee of Headway 2025 to the second day of insightful sessions. We hope you enjoyed yesterday's sessions, so let's dive into another day full of learning with an exciting lineup of talks and activities ahead. I would like to introduce and welcome our next speaker, Dr. Shiv Shankar Paul sir. He is currently working as a medical director and chief consultant at ENT and head and neck surgery at Eve's Clinic Multispeciality Hospital, Kolkata. Sir is an associate professor at Department of ENT and head and neck surgery at JMN Medical College in Chakdaha, West Bengal. Sir has multiple internationally and nationally published articles to his name. Sir has an experience of more than 8 years of work in ENT and head and neck surgical oncology. Sir will present a talk on locally advanced cancers of head and neck and how should we approach. The chairpersons for this session will be Dr. Somendu Guha sir and Dr. Monotosh Datta sir. Sir, please.
Okay. Good morning to the respected chairpersons and to the guest faculties and to all the delegates. First of all, I thank to my department, to this medical college and to my department, since I'm an alumni of this college and this is my alma mater. And I'm really grateful for and I'm really humbled to present a paper at my own medical college hospital. So today we are discussing regarding locally advanced cancers of head and neck and how should we approach at our OPD, at operation theaters, even post-operative managements. See, locally advanced head and neck carcinomas of head and neck is a very vast topic because it includes multiple subsites. So what are the dilemmas we face when we approach a locally advanced? First of all, think, what is locally advanced? It is stage 3, stage 4 and stage 4A, stage 4B. So first of all, we have to stratify, is it early stage or is it a late stage? How will I assess at the OPD? How will I approach? If it is a locally advanced, is surgery possible or should we go into any other modalities of treatment? How will we go for a tissue diagnosis? Then we need to do imaging, staging, and what will be the most appropriate treatment modality, and that should be discussed via MDT, that is multidisciplinary tumor board, so that we could prevent further delay to our treatment which is already delayed. And how will we counsel the patient as well as patient skin, and we have to assess or we have to imply what will be the most treatment benefit based on the risk and the survival ratio, and whether we will able to give any proper treatment or should we go for a palliative care, and does this provide any benefit or not. So the disease burden in our society, the current status, the head and neck cancers accounts for 4.9% cancers globally and 19.5% cancers of all over in India. Now the head and neck cancers, particularly the head and neck squamous cell carcinomas, are the second most common cancers in India, with a male is to female ratio of 3.6:1 and is responsible for 17% of cancer related deaths in India. So it's a huge burden in our society. So these are few pictorial pie charts of the percentage of cancers. Now, usually assessment, management and approach differs as per subsites. For example, lip and oral cavity, we know that buccal mucosa, alveolus, palate, oral tongue, floor of mouth. It is mostly squamous cell carcinoma, and which constitutes at least 50 to 60% of our daily OPD turnover. Rest, it involves the base of tongues or oropharynx, laryngopharynx, sinonasal malignancy, skull base, then major salivary glands, the thyroid gland, and the rare subsites like the ear, lateral skull base, and the metastatic neck nodes of unknown primary. So these are the subsites, and according to the subsites, the management depends. Now, overall, there is an evaluation and staging workup which should be done in the OPD. We should take the disease-related informations, the habits, the addictions, the medical history, whether there are any comorbidities or not, even the physical examination, the performance and nutrition status, as well as the ECOG status. We should always assess that. And we need to document the primary. We need to draw a diagram that where is the disease, what is the size, site, and whether there is any metastatic palpable neck nodes. This has to be assessed. Now, we have to see a clinical evaluation, whether is it operability regarding not resectable or resectable, okay, and cranial nerve examinations, particularly for nasopharyngeal and paranasal sinus tumors. For example, if you are seeing a tongue carcinoma, you know the depth of invasion has been introduced in the TNM staging. So you do a bimanual palpation. Okay, you have to put your fingers in the mouth, isn't it? Durse dekliya, it is not like that. You need to put your fingers in the mouth. You need to assess it. You need to assess the size, the depth, and see in the picture how they're doing it, holding the tongue with one hand and another by palpating the tumor by 2 fingers, isn't it? So we will do endoscopy, biopsy and imaging wherever it is feasible. For example, endoscopy for a base of tongue or a laryngopharyngeal growth, or evaluation under anesthesia if it is difficult to assess clinically at OPD. For example, there is restricted mouth opening, so you need to assess by under anesthesia. Then we need to go a biopsy plus minus ISC wherever indicated, FNSC from the nodes, and for oropharyngeal lesions you can go for HPV status, which we call ABRISH, and definitely we should go for imaging, CECT or CMRI or FDG PET, but we have to advocate which is the optional and which is the optimal. CCT is the optimal, or MRI, but FDG PET is in some subsites it is optional, but in some subsites it is optimal. So PET scan, when should we do it? Should we do it in all cases? No, we should not do it in all cases. So what PET CT does is that we assess the metabolic status of the tumor. It is a valuable response assessment of post-treatment settings particularly. For example, if we see multiple lymph nodes and we cannot see any primary disease, so it may be metastatic disease of unknown primary, it may be lymphoma, and you did a tissue diagnosis and you did a neck node biopsy, and ISC it comes out to be lymphoma, maybe Hodgkin's, maybe non-Hodgkin's. So you need to go for a PET CT scan to assess any other sites are involved or not. Okay. For example, a stage 3 oral carcinoma, CCT face, neck and thorax is sufficient to assess it. Nowadays, PET CT scan has also come into staging. Okay. So there's few dilemmas with the SUV max, particularly post-treatment. So you treated either by surgery followed by adjuvant radiotherapy, or you did a upfront chemoradiation, and you are assessing the response of 12 weeks post-treatment, and you are seeing it, there is a subel uptake per se less than 7. So is it a residual, is it a recurrent, or is it an inflammatory? So PET CT scan also have some limitations which really puts us in dilemma. Now clinical staging, I'm not going to depth into staging, but what it marked in the green color, this is the stage which we act now. In any of the stage, see, the concept is the earlier we treat, the patients who comes at the early stage definitely has a better prognosis and better survival, overall survival as well as 5-year survival. But T1, T2 treat with N1 or the T4A, N1, if we address that patient properly and perfectly via MDT and given the best possible management, then the patient has a good chance of a 5-year survival, disease-free survival. Now MDT, because it is the backbone of decision making, do not take your decisions personally. There should be MDT, there should be surgical oncologist, medical oncologist, radiologist, radiation oncologist, pathologist, and patient kin or the patient himself. So the MDT should be carried out to discuss, to assess the locally advanced cases of the head and neck. So why? See, T1, T2, T3 with N0, it is easy to treat for oral carcinomas. You can do surgeries, and you can, as per the final histopathology report, you give the adjuvant treatment. But this T4, N3 disease are very difficult to assess because we have to think of the patient's age, whether there are comorbidities, and accordingly the risk benefits. Okay, risk is to survival benefit. We need to assess it. So this is the overall survival in oral cancer patients after adjustment that has been given in MSKCC, which I have taken out. The stage 4 is stage 4B. You are seeing that as and when the months progresses, the percentage of survival goes really down. Now the treatment philosophy, a general overview. See, for a stage, there is 2 types of treatment, a curative intent and a palliative intent. So the curative intent are non-metastatic diseases with a good performance status. Okay. So we have to select which are the patients and what modality will apply for that. For example, for an oral carcinoma, for a stage 1, stage 2 disease, definitely surgery is preferred over radiotherapy. But when it comes to organ preservation like larynx and hypopharynx, then we prefer radical radiotherapies because it gives similar results as surgery, less morbidity and organ preservation. But for stage 3, stage 4 disease, a multidisciplinary approach, which I always said, which is marked in red. For nasopharyngeal carcinomas, you can give upfront chemoradiation, or you can give induction chemotherapy, assess, and go for chemoradiations. For paranasal sinus, for T1, T2 disease, because it's a very difficult sites to reach, so negative free margin is quite difficult to achieve. Apart from maxillary sinus carcinomas, for example, for ethmoids and sphenoids and skull base, so it is very difficult to get a margin at this skull base. For the sinonasal malignancy involving the maxilla, you can go for maxillectomy, but it also depends upon the site, that is, we know the Ongren's line, because it has a prognostic factor, that anything below the Ongren's line has a good prognosis, better resectable outcomes, and a negative free margins. Anything above the Ongren's line, we have to go for a minimum of subtotal or total maxillectomies if orbital involvement is there. Orbital management has to be done, but the prognosis is poor. For larynx and hypopharynx, it is always suitable for a organ preservation. That means you can go for stage 3 supraglottic or glottic carcinoma, you can give induction chemotherapy, followed by, and you assess the response after 2 to 3 cycles of induction chemotherapy, and then you can go for concurrent CTRT. Now the palliative intent, if it is, whether it is metastatic with poor performance status or non-metastatic with a poor performance status. Now the patient is at a good performance status, then our main goal is to control the symptoms and also reduce the disease burden so that you can give a little bit better quality of life. Okay, so you can give any chemotherapies, including any, you add any systemic therapy, like say, along with, for example, you are giving chemotherapy with nab-pacli, with paclitaxel, with carboplatin, and 3 weekly and 2 weekly you are giving cetuximab, or if you can see the PD-L1 expression and you can add any immunotherapies like pembrolizumab or nivolumabs. And if it is a poor performance status and metastatic disease, then our goal will be only symptom control and based supportive care. Yes. No, mobile term. So I will discuss when to apply the best modalities of treatment, that is upfront surgery followed by adjuvant RT or CTRT, if CTRT if margin positive or external extension is there, and when we should give ICT or NACT. See, NACT in oral cancers is really controversial because there are lot of trials which will be coming. Okay, treatment by radiotherapy or concurrent chemoradiation, as I discussed, palliative intent chemotherapy plus minus targeted therapy or immunotherapy. Remember, when you are doing a surgery for also locally advanced cases or a borderline resectable, you have to assess whether I will get a clear margin or not. You have to get a histological clear margin. That means minimum of 5 millimeter. That means surgically you have to go beyond 1 centimeter. So what is close margin? 1 to 5 millimeter, and involved margin is less than 1 millimeter. We need to go for a R0 resection. If you cannot go for a R0 resection for a suspected borderline case, don't do it, because that will pose more trouble, most post-operative problem to the patient. Complete neck nodal clearance is very much mandatory. At least histologically there should be more than 18 detectable nodes that has been examined. That is adequate neck dissection. You have to do it. And reconstruction options, you need to assess that whether I will give pedicle flaps like PMMC, or should I reconstruct it with a free flap, that may be ALT, that may be osteocutaneous flap for anterior mandibular defects. The surgery is not only the goal. The surgery, the disease removal is not only the goal. You have to give a functional outcome. So what is the functional outcome? Functional outcome is that whether the patient is able to swallow, patient is able to speak, the speech and swallowing rehabilitation, as well as a acceptable cosmesis. So resectable or non-resectable, how will I assess it? So there are few important points for oral cavity lesions. The trismus grade 3 or grade 4, it denotes a masticator space or high infratemporal fossa involvement. That is pterygoid muscles and all those. And you have to decide, is it a high ITF or low ITF? High ITF denotes is by the sigmoid notch. That is the notch between the coronoid and the condyle. Anything above that is a high ITF, anything below it is a low ITF. So in oral tongue, whether it has gone to the oropharyngeal part, that is the base of tongue or not, is there an extensive palatal involvement, or is there ethnic involvement of the prevertebral fascia or cervical fascia or not? So you have to assess clinically as well radiologically whether these are the subsites for oral carcinoma, involvement is there or not. By that way, you assess the operability as well, or inoperability. Now, as I said that ICT and NCT for locally advanced head and neck carcinoma, it is controversial. It is not controversial for laryngopharyngeal where organ preservation is there, but it is controversial for the oral malignancies, head and neck squamous cell carcinoma, because we still have a dilemma: what will be the margins? Will we take the previous margin or should we take a neo margins? Now there are a few trials previously done: Spain 19 tax 324, URTC, then TTCC, GORTEC, RTOG trial for laryngopharynx. Now, see, since I have discussed NACT, in our institute at Saroj Gupta Cancer Centers, we are giving some trials and we are seeing patients of a locally advanced cases by giving NACT, particularly for only extensive mucosal diseases for organ preservation. So this patient who had a locally advanced CA tongue crossing the midline and approaching to the posterior third and floor of mouth also, with not complete ankylogloss, partial ankyloglossia. So we subjected this patient to a TCF regimen, this taxane platins and 5-fluorouracil, because the patient was young, approx 35 years of age, and patient has a good ECOG status. So we subject to 2 cycles of NACT, reduces in a shrinkage, as well as we assess it via MRI, CMRI contrast to see whether there is any skip lesions or not. Because our motto was to, for our organ preservation, for at least we can give most of the, save most of the tongues. Yes, you can go for a near total glossectomy and we can put a free flap. This patient does well good, but the problem lies with the speech, with the tongue mobility, with the tongue swallowing, helping in swallowing. So we didn't put up this for a free flap. We subject to NACT for this patient, we assessed it, and there's a significant reduction in size, and we did hemiglossectomy by a marginal, paramedian mandibulotomy approach. And if I see the tongue mobility, this is the tongue mobility after we reconstruct with a PMMC flap. So the patient is able to move the tongue properly, so the patient has a good speech and patient can swallow food properly. So in a nutshell, locally advanced stage 3, stage 4, we have to see resectable or not resectable. If it is resectable, then surgery followed by follow-up, or depending upon the final HP report, or concurrent CTRT. And for those for organ preservation, we go for upfront chemoradiation or induction chemotherapy followed by concurrent CTRT. For unresectable, you can go for upfront CTRT or induction chemotherapy followed by CTRT. Now these are algorithms for advanced carcinomas of oral cavity. So stage 3, stage 4 resectable, surgery plus adjuvant therapy should be there. And borderline resectable, that is the most worrisome part. So if it is borderline resectable with good GC, you can try NACT. If it is a good response, you can re-evaluate for surgery followed by adjuvant therapy, or if it is inadequate response, then you can, or a progressive disease, you can go for upfront chemoradiation. And for unresectable, as I said, for good GC, you can go for chemotherapy. For poor, just symptomatic treatment. Now this is the advanced C. Now this is the advanced case of oral carcinoma. See, there's an extensive buccal involvement as well as involvement of the cheek skin. So we have to take a wide margin, and we can reconstruct with a PMMC flap, giving a good cosmesis, giving a good mouth opening. The disease clearance should be very crucial. Please do not compromise on margins. Reconstruction should be adequate. Reconstruction should be such so that postoperative postoperative outcome and the postoperative rehabilitation becomes very much easy for the patients. Now see, both the patients are having same subsides, more or less the same size, but one had a very restricted mouth opening and one had a good mouth opening. So by this picture you can understand what is resectable and what is not resectable. Okay. So this you need to assess at the OPDs. Now the decision making for borderline resectable, I told you that it has to be taken by a multidisciplinary tumor board. But note one thing, radiological involvement of the infratemporal fossa, which is inferior to the level of mandibular notch, is deemed as resectable for current surgical techniques. For example, the patient is coming with a trismus and the lesion is below the supra notch. So you don't go to a final decision that is not resectable. You assess the imaging. The trismus may be due to the associated oral submucosal fibrosis. That doesn't put the patient as a non-resectable candidate. Okay. Now see, this is rather a huge bulky oral cavity lesions involving the more than 1/3 of the lip, the cheek, soft tissues. So from outside it is looking like a non-resectable, but whenever we have assessed it with an imaging as well as mouth opening and others, as well as evaluation for any distant mets or not for such a locally advanced case, when there is no evidence of distant mets, we went for an upfront surgery, giving a wide margin. You need to see the margin, see the margin we have taken. Because for a cutaneous spread, there will be skip lesions. Yes, I do agree, whatever modality you give to such a locally advanced case, it may recur within the first 2 years of life. But still we should try and give the best possible care, best possible quality life support to them. Now this patient similarly is a fungated lesion involving the cheek but going towards zygoma. So it is more of a soft tissue lesions, skin cutaneous fungations rather than going to the high ITF. So we resected it and we reconstructed with a radial forearm free flap. So these are borderline resectable cases. Now the problem lies with the recurrent head and neck carcinomas. Now for the recurrent cases, for example, you did the surgery followed by adjuvant therapy or upfront any other therapies you have done it, and you see a locoregional recurrence. So if you see a locoregional recurrence, if it is resectable, go for salvage. No other mode, go for salvage. If it is unresectable, if you see it, if it is within 2 years of radiation, then don't go for re-irradiation, go for other modalities. Because if you give re-irradiation within the first 2 years, then the patient have a very bad radiation-induced side effects. Most of the places they advocate 1.5 years also, but if they have taken a recent radiotherapy, go for other modalities, chemotherapy combined with an immunotherapy or any targeted therapy, you can give it. And for distant metastasis, you have to see if it is a disseminated or is an oligometastatic. If it is disseminated, then go for a systemic therapy and palliative radiotherapy for locoregional or bone control. If it is oligometastatic, then you can do a metastatic SOMI or SBRT. And if it is a poor performance status, then only the best supportive care will help the patient. Now this is a recurrent squamous cell carcinoma. This patient had got operated for a buccal carcinoma in 2019, presented to us in 2025 with a recurrent disease. So it is around 6 years down the line. So we assess it via FDG PET. We did a tissue diagnosis because it is after so much after 5 years, 6 years later. So we did a biopsies. It's a recurrent squamous cell, then followed by an imaging. For recurrent, that is not eye, but it is the recommended protocol. You can go for a PET CT scan. Yes, you can go for CCT face, neck, thorax, but for recurrent cases, PET scan is far more superior to rule out any distant mets to be confirmatory. And we did a reconstruction by a PMMC flap. And now the question arises, why didn't you go for a free flap? This, as per the picture, you can see this candidate is a very young patient. At very early age, he developed oral carcinomas. So we did it with a PMMC flap so that if any other subsites carcinoma develops, so that we have a chance for another salvage with a free flap. For example, recurrent supraglottic carcinomas. For laryngeal cancers, organ preservation is now the first modality. Now in few cases, we give a radical RT or upfront chemoradiotherapy, and the patient did good post. There is a complete response. Now the patient came after 1 year or 2 years or 3 years with a recurrence. That may be any subsites of the larynx. Now this patient had a recurrence at the supraglottic part, that is the epiglottis, laryngeal aspect of the epiglottis, close to the false chord. So we did a PET CT scan. There was no other evidence of distant mets. We did even a CE MRI for a particular surgical planning for salvage. Rather and then we thought that okay fine, when we have a good margin, let us go for a supraglottic partial laryngectomy. Then why didn't you go for a total laryngectomy? Because I am getting a margin below. I want to mean that for larynx, hypopharynx, give as best organ preservation technique. Go for the best organ preservation technique, even for recurrence. See, this is a epiglottis, laryngeal aspect epiglottis. So when on the CMRI as well as the PET CT scan, there is no further involvement of any other subset of the larynx and hypopharynx. So why not we go for a supraglottic partial? You can see the margins which we have taken, isn't it? You can see the below margins. Okay. So if we get these margins and we can give a good organ preservation, the patient has a good swallowing, patient do not need any Provox or Bloom-Singer's prosthesis, patient has a good voice. Yes, some patients have little bit of swallowing difficulties because of high risk of aspiration, but if you go for a proper cricohydropexy, then the chance of aspiration is very less. I'm not saying that it will not happen, it is negligible and patient can tolerate that. So after operation, see, after surgery we have done a fiber optic laryngoscopy at least 7 to 8 weeks post-op. See the base of tongue, এখান থেকে এটা কি বলে পয়েন্টার this one না
এটা কি স্যার অন্য সফটওয়্যার আছে না অফিস আছে
অফ দেখুন পয়েন্টার
স্যার
ওকে
অ্যারো
না অ্যারো তো আছে
অ্যারো না স্যার এই সরি স্যার ওখান থেকেই আসবে স্যার
ওকে ওকে নো ইস্যু
এই যে এখানে আছে আপনার
ওকে
স্যার আপনি এখান থেকে চেঞ্জ করতে পারবেন স্যার
ঠিক আছে okay, no problem. So this is the see this is the base of tongue, and along with see the glottis part. So we have preserved the false chord, we have preserved the true chords. So this is a good hydropexy, isn't it? So the patient, you can see there is a little bit of pooling of saliva at the lateral aspect, white color is there. So this little bit will be there. Now see, 1 month post-op, patient is still with a Rice tube, and we have given the patient first liquids, then still we didn't remove the Rice tubes. We asked the patient to have some semi-solids and send us a video at home, but rather he chose to have noodles. And see how he is swallowing. He is swallowing by putting his head low to prevent the aspiration, because whenever he puts the head up, he had a little bit of aspiration and coughing. So he is putting the head low and having the food, and see, without coughing the patient is able to have food. So the basic focus of surgery is not only disease clearance, the post-operative outcome, the swallowing, speech, rehabilitation, that is very important. Now see, the patient is having very wonderfully, and now the patient delayed post-op, and see the bulk of food he is taking now. The sound.
Squamous cell carcinoma 2 years ago, post chemoradiation, presented with a recurrence after 2 years of complete clinical response. Patient underwent supraglottic partial laryngectomy, and post surgery 3 months, post salvage surgery 3 months has passed. Now the voice. নাম বলুন।
আব্দুল মাজিদ,
বাড়ি কোথায়?
বাংলাদেশ।
খাবার খেতে কোনো অসুবিধা হচ্ছে?
না, অসুবিধা হয় না, কোনো কাশি নাই।
খাবার খেতে গেলে কোনো কাশি হচ্ছে?
না, কাশি হয়
বা খাবার খেতে গেলে হঠাৎ করে শ্বাসকষ্ট হয়ে উঠছে?
না।
ভয়েসটা পড়ে আসছে কথাটা। So see the speech. See the speech. Such a good speech. Patient is without tracheostomy, and he is saying that he has no problem of having foods, and it's a good acceptable voice. So in that case, if you have gone for a total laryngectomy, so that would have been overdoing for this patient, because the patient having a preserved voice. So the objectives of salvage surgery in recurrent head and neck cancers to provide overall survival benefit. that is the first important, to achieve histologically adequate negative margin, which I am giving an emphasis. If the MDT have any doubt about margin clearance, rather not operate. Provide a suitable functional integrity for swallowing and speech so as to improve the quality of life. You operate at any subset of the oral cavity and oropharynx or laryngopharynx, the patient will definitely have an impact on swallowing and speech. So you have to provide the best functional integrity. Cosmesis is supporting functional integrity also. Okay. For example, you are afraid of doing a pedicle fab and you have done a small flap compromising the margin, the patient have a small mouth opening and patient cannot open the mouth, or post-operative patient has a trismus. So patient will come to you and say, sir, you operated me, and after surgery, see, in few surgeries you have seen that whatever we are giving a free flap, for example, radial forearm for the buccal mucus, and the patient came out with a trismus. Now the patient says, you operated to my patient, the patient, at least he was able to have food. Now after surgery, okay, fine, there is no disease, but the patient cannot have food because the patient have a complete trismus. So that is quite a dilemma. So you choose the appropriate reconstructive techniques. See, oropharyngeal cancer, not going to so much of details. For stage 3, stage 4 disease, radical intent, you have to give concurrent chemoradiotherapy is the treatment of choice. Or you can go for ICT followed by chemoradiotherapy. And you have to assess definitely for any subsets of oral cavity or oropharyngeal lesions, reassess after 12 weeks clinically, endoscopically, as well as by an FDG PET or CT or MRI. For example, the primary responded well and there are residual neck nodes. Assess it clinically, is it mobile or not? Can we go for a planned neck dissection or not? So go for a planned neck dissection. So as I said, locally advanced CL larynx, for that organ preservation is the ultimate goal. But for those having a stage 4A disease, thyroid cartilage involvement, or with a poor laryngeal function, then total laryngectomy is the choice. Number 2 is that please go for primary TEP. Yes, there are 2 options. You can go for primary esophageal tracheoesophageal prosthesis or a secondary setting. But in our centers, we always go for a primary TEP. It gives a good outcome. There is no such risk of leakage if you use a proper introducer, whether for a Provox or whether for a Bloomsingers. And if you are one size, for example, if you are doing a puncture of, for example, the diameter is 8, so you can use a Bloomsinger of 8 or another one higher 10, so that it snugly fits at the posterior wall and there is no blockage of the valve. The patient should clean the valve himself by seeing at the mirror, and there should be adequate stoma. The size of the stoma should be adequate, so that tracheostomy post-surgery tracheostomy tube you need not to put inside. You can use a simple Larry tube, so that you can put a HME speak-free valve, so the patient doesn't have to put the finger and speak. Okay. So I said T4 laryngeal carcinoma, organ preservation versus total laryngectomy. So organ preservation can be attempted, but there is, for example, thyroid cartilage. We got few cases having just borderline, they have just involved the thyroid cartilage, and we have we have put the patient on NSCT followed by chemoradiation, and we did imaging post therapy, and they are doing nice. But there is little bit of dilemma for a T4A. Some centers is saying that for a T4A with a little bit of thyroid cartilage involvement, let us not go for total laryngectomy, let us go for chemoradiation, we assess it, and if we see, okay, there are residual disease, then we can go for a salvage total laryngectomy. So organ preservation is very important. Now see this is not a case for organ preservation, as we know, see these are very much extralaryngeal spread with a gross cutaneous involvement. So we had gone for a total laryngectomy and partial pharyngectomy, and we are also supported with a PMMC flap. So post-op swallowing rehabilitation. So we didn't put the HME filter this patient will definitely, this is a recent one. See, with less effort, the patient is able to speak. Now he is putting the finger over there to press the valve, but it is not necessary because nowadays with the Larry tube, there is an HME filter and there is a speak free valve also. So the patient did not need to press over there. So this improves the quality of life. Now the inoperable neck nodes for larynx and hypopharynx, if it is an ECOG status good, that is a performance status goods, then go for NSCT, the same thing, followed by chemoradiation. If the performance status is poor, then go for palliative intent therapy. Now another subset is the salivary gland. For a malignant salivary gland, most of involve the parotid gland. Assess the resectability. If it is resectable, go for dissection. Even the facial nerve is involved, go for total. If it is non-resectable, the salivary gland non-resectable comes when there is an interdural or skull base extension or there is an carotid extension, encasement. That comes the inoperability. Other than that, it is upfront surgery. And adjuvant therapy for malignant salivary gland involves the T3, T4 cancers, close or positive margins with a lymph nodal metastasis, or high or intermediate grade tumors, not for low grade tumors, deep lobe involvement or recurrent cases. Now see, this is significant cutaneous involvement involving the tracheal cartilage. So histologically it was a high grade mucoepidermoid carcinoma. So we did a total parotidectomy, conservative parotidectomy, and did a neck dissections followed by reconstruction with a PMMC flap. You can reconstruct this area with a PMMC flap. You can go for a cervical flap also, but since the area of excision is quite large, so cervical flap is inadequate. So there is no tension for the flap. So we did a PMMC. Suranasal malignancy, yes, definitely it's a very difficult site to approach for us ethmoid, sphenoid sinus tumors. For maxilla it is not, you can go for partial or subtotal or total depending upon the area of involvement. Nasopharyngeal carcinoma, you need a little bit of workup. You need nasal endoscopy, you need a PET CT, and you need also, you may go for an EBV workup, and you can, if it is an advanced case, you can go for induction chemotherapy, assess the response, followed by chemoradiation. Now another subset is locally advanced thyroid cancers. See, thyroid is a very vast chapter. I mean, Sir has explained much more better yesterday in his lecture. But locally advanced cancers, which refers to advanced or invasive thyroid cancers and those grossly extending beyond the thyroid capsule, that is important, or involving the recurrent laryngeal nerve or trachea, larynx, esophagus, or major blood vessels. Okay. So you should assess by FOL, as Sir said, that FOL assessment for the vocal cord mobility is important. Okay, whether it is involved or not, whether the patient present with a vocal cord hoarseness of voice or not. FOL examinations for the PGs is mandatory. Everybody need to do it. Do not miss it. So if you are suspicious the patient is having a dysphagia or sometimes coughing out blood, then other than FOL also you go for upper GI endoscopy whether there is an esophageal wall involvement of there or not. A combination of preoperative USG and CECT provides a reliable and objective and complete preoperative mapping for an advanced cases. Now the principles of surgery in a locally advanced thyroid cancers, all patients with locally advanced thyroid cancer should undergo total thyroidectomy with removal of all gross tumor to achieve an R0 resection. Try to resect all gross. Sometimes there is a metastatic DTC and the tumor is so gross, so big that it is going to the mediastinum. So the role of debulking is there for DTC as well as miliary carcinoma thyroid. So for this, go for the gross tumor resection. So try to preserve the function and vital structure, strike a balance between complete resection and sacrificing of vital structure. Intraoperative nerve monitoring, though not mandatory, but helps to identify the function nerve when the recurrent laryngeal nerve is involved. Now see, this is a locally advanced thyroid carcinoma. Rather, we have to go for a completion. So this is involving this thyroid tumor is going extra thyroid and involving the cutaneous spread, involving the skin of the neck. So we planned it accordingly, how will we close that area. So we took a triangular type incision, and when you opened it, surprisingly, we have seen, you can see this where my cursor is, the upper pole of left thyroid gland was there. The patient was not subjected to any other therapy. That was a very poor surgery which has been done outside elsewhere. So from there the recurrence happened. Even you can assess the neck nodes over here, the third metastatic neck nodes going till the at least beneath the clavicle. See, for DTC, yes, most of the tumors are adherent, but still you can go for a finger dissection and can pull it up. Okay. Now, post surgery, post excision, see the disease clearance. This should be the disease clearance. This should be the disease clearance. You have to remove all the gross tumors, all the metastatic neck nodes. I have sacrificed the IGV because the IGV was encased. Don't be afraid of sacrificing the IGV. Try to preserve, if not able to preserve. If it is adherent to adventitia, you keep on poking over there, resulting bleeding, and you're giving multiple sutures, resulting a very narrow band of IGV doesn't implicates of keeping that IGV. Okay. So sacrifice, yes, another side should be preserved. So this is the specimen, the gross tumor with the metastatic neck nodes and the closure of the wound, and this is 4 weeks post surgery, the outcome. Now the RNA encased or invaded, should you sacrifice or not? Try to preserve the nerve. Try to preserve the nerve. If at all you cannot preserve the nerve, try to anastomosis. Okay, if a nerve is dissected at surgery, an attempt must be made for an immediate repair, that is end-to-end anastomosis or a cable graft. And another option is immediate medialization thyroplasty may be considered. Like for example, you see the recurrent laryngeal nerve having a 360-degree encasement at its entry to the cricopharyngeal junction, isn't it? So initially we tried to shave off the tumor to preserve the recurrent laryngeal nerve, but still we are seeing a gross residual tumors. So we planned for a sacrificing of the recurrent laryngeal nerve by informing the patient. Medialization thyroplasty can be done if you sacrifice the nerve, and you can see the voice post medialization thyroplasty also. Voice
right, locally advanced. He underwent total thyroidectomy with bilateral selective neck dissection with central compartment neck node dissection. On central compartment dissection, patient had an involvement of the recurrent laryngeal nerve, that is the nerve is encased by the node. So we had to sacrifice the recurrent laryngeal nerve for disease clearance. And post procedure and post adjuvant radioiodine therapy, we had operated on this patient for a type 1 thyroplasty, Ishika's thyroplasty, that is medialization of the vocal cord to improve the voice. Now post thyroplasty, the voice is quite good and acceptable. Initially it was totally husky. Now the patient has a acceptable social voice. আপনি এখন কোথায় আছেন?
আমি এখন ঠাকুরপুকুরে আছি,
আচ্ছা,
ক্যান্সার হাসপাতাল।
ক্যান্সার হাসপাতালে আপনার ভয়েস আগের থেকে কেমন উন্নতি হয়েছে?
স্যার আগে তো অনেকটা ভালো হয়েছে, আগে কথাগুলো অস্পষ্ট ছিল,
এখন কথাগুলো স্পষ্টভাবে বলতে পারছেন?
জি
ঠিক আছে। কথা বলতে গেলে খুব গলায় বাজছে এরকম হচ্ছে বা কাশি হচ্ছে কি?
জি না, এমন হচ্ছে না। মাঝে মাঝে ঠান্ডা লাগলে আমার মনে হয় যে কফটা আটকে যাচ্ছে।
সেটা তো কমন কোল্ডের জন্য, এমনি কথা বলতে গিয়ে আটকে যাচ্ছেন, শ্বাস আটকে যাচ্ছে এরকম?
জি না, এমন হচ্ছে না।
So for the locally advanced thyroid cancer post surgery, you need to assess the risk. You will get it in ATI guidelines. The load is intermediate and high risk. So it is a rare subsite. This is yes, my speech is getting quite longer, but this is a very interesting one. So the patient has a squamous cell carcinoma, right external aortic right pinna, as well as involving the external auditory canal skin, not invading the middle ear cleft, and the anterior extension involving the superficial lobe of the right parotid gland with metastatic neck nodes. So we went, so this is the incision which has been planned for, okay, with a wide margin. Even the you can see the redness, the cutaneous infiltration by the lesion, okay, involving the parotid tumor or parotid gland also. So this is the margin we have taken, that is pre-auricularly as well as the post-auricularly. And we subjected to the modified neck dissection, and then we did, by the digastric approach, we did a superficial parotidectomy exposing the facial nerve trunk, and then we did a wide cortical mastoidectomy to expose the posterior wall of the external auditory canal. Okay, you can see the incus starting out. So why I did it? To get the posterior margin. If we go at all for a sleeve dissection of the squamous of the external auditory canal skin, so that is not an adequate margin. For example, as we do in marginal mandibulectomy, it is a lower GB sulcus growth, gingivobuccal sulcus growth, but we take a marginal mandible to get the margin. So at all, only removing the skin is not adequate. You may leave the disease over there. So for the posterior margin, I have taken the whole bony external auditory canal up to the annulus. So that I drilled it, and then I drilled over here, thinning of the canal at its attachment, and whole canal has been pushed forward. So see, as and when we have pushed it forward, the whole specimen just came out. Along with, you can see the nerve coming out from the stylomastoid foramen. And this is the en bloc specimen resection, and we reconstructed with an ALT free flap because of this very gross defect. And postoperative facial nerve function, you can see there is closure of eyes, but there is a little bit marginal mandibular nerve injury. And late postoperative post-radiotherapy, the status. So key points in managing resectable: appropriate surgical planning, en bloc resection, functional reconstruction, initiate swallowing and speech rehabilitation, and timely starting the adjuvant therapy and close OPD follow-up. Last of all things, a rare scenario, dual or synchronous primary. I think everybody is getting that. Patient had presented with squamous cell carcinoma, buccal mucosa, and we operated with, we did the neck dissection. Now the neck nodes came out to be a papillary carcinoma thyroid. Patient didn't had a clinically palpable nodule, not even mentioned as a sizable nodule in CT scan also. And when we did a neck dissection, that came out to papillary. Now the dilemma arises, how will I approach? Now squamous cell with a papillary, so synchronous. So we put on the MDT. So the MDT said, okay, let us go for now the thyroidectomy. So immediately 10 days, 15 days later, we went for a thyroidectomy. Then we subjected to adjuvant radiotherapy for the squamous cell carcinoma because it is more virulent. After that, after treating that by adjuvant therapy, now the dilemma arises, should we go for radioiodine therapy? Iodine therapy we must, but when? Is it immediately or delayed? So we waited for another 8 weeks, 2 months post radiotherapy. Then we initiated the radioiodine, planning for radioiodine therapy, that is holding the L-troxin for at least 3 to 4 weeks prior to therapy, and then we initiate the radioiodine therapy, and the patient is doing nice. And for palliative OMCT, targeted or immunotherapy for recurrent residual or unresectable cases. Thank you.
Thank you so much, sir, for such an insightful session. Now, may I request our next speaker, Dr. Rajiv Sharan, sir, for his next talk, which is minimally invasive thyroid surgeries, robotic as well as endoscopic. The chairpersons for this session will be Dr. B.K. Bhattacharjee, sir, and Dr. Radhesham Mahato, sir. And also Dr. Alok Bose Majumdar, sir.
Okay. Yeah, yeah.
I now request our Head of Department, Dr. B.K. Bhattacharjee, sir, to kindly felicitate Dr. Shoradeep, sir. Dr. Shoradeep is currently the professor and head of department ENT, Kuch Bihar Government Medical College and MSVP.
Student, sir? Okay. Should I start? Okay. A very good morning, everyone. I would like to thank again organizer for giving me this opportunity. I am going to speak about remote access thyroid surgery. So this is, so topic was minimal invasive thyroid surgery, but this is not minimal invasive, but remote access thyroid surgery. So what is remote access thyroidectomy? This is a method of removing the thyroid gland without giving any incision in the neck. This can be done with endoscope or this can be done with robotic system. This is given a definition by American Thyroid Association. So why remote access thyroidectomy? So classical approach, that is transcervical approach, gives an excellent exposure to the and a direct access to the thyroid gland. So everything is in front of your eyes. So why do you want remote access thyroid surgery? But at the same time can lead to neck scarring that negatively impacts patient quality of life. So here you can see these two pictures. So first one is 19 years old girl with thyroid cancer, and this is a post-op picture with neck scar. Every time she comes, she asks for how to get rid of this scar. The other picture, 16 years old girl from Manipur. She came with a thyroid nodule with bilateral neck nodes, but she wanted remote access. She did not want any scar in the neck. So we did robotic total thyroidectomy with bilateral neck dissections and central compartment clearance. Now she has joined MBBS and you can see the neck picture. So she looks perfectly normal. So open thyroid surgery, maybe 60-70% of the time, scar will be good and well hidden. But 20 to 30% of patient, it can be ugly or it may be very worse. So this is very interesting study by Choi et al. And they showed scars in the neck affect the quality of life of thyroid cancer patients regardless of scar type. And if you see these components, so clothing was the most commonly affected components due to neck scar, because they have to hide the scar and they wear high neck dresses to hide these scars. So their leisure activities, they feel embarrassed in social functions and all. So this is another study by Arora et al. And they found no correlation between scar length and patient scar satisfaction. So a scar is a scar, whether it is a small scar or it's long scar. And quality of life in patient with visible scar was worse than when scar was well hidden. So I got opportunity to be trained in endoscopic thyroid surgery in Bihar in 2015. I was in Hanoi for few weeks with Professor Luan, and he is a pioneer in endoscopic thyroid surgery. So what is endoscopic thyroid surgery? Professor Luan's technique, and here he used to give 2 5 mm incision in the anterior axillary line and periareolar region, and 1 10 millimeter scar in the mid axillary line for the cameras. And with these ports he was able to do hemithyroidectomy from one side. And here yesterday I mentioned 2 approaches for the thyroid gland, midline approach and lateral approach. So these remote access thyroidectomy, most of them use lateral approach. So here you can either lift up the sternothyroid and the sternohyoid together to get around the thyroid gland, or you can split the sternothyroid muscles in the line of muscles fiber, so that muscle fiber function will not get affected. And here you can see these are the port sides. So just 5 mm 2 port and 1 centimeter 1 port. And with these ports you have to dissect whole of this region. So shaded area you have to dissect underneath like a normal thyroid surgery. You have to raise subplatysmal flap in the neck. And this was my first case in 2015 with all 3 ports. And here this was the specimen, and here you can see this was the pre-op pictures with the nodule on the right side, and the other side is this is post-operative pictures. And the scar wise you can see after 2 weeks that was all fading. So maybe after 4 weeks and 8 weeks that will be completely gone. Because I was not happy with this technique, because this was good for non-malignant cases and I was doing mainly malignant cases, so I wanted to do something more. And with transaxillary endoscopic approach I was not able to do what I wanted to do. So I got opportunity to train under Professor Ko, and he is the pioneer in robotic head and neck surgery. So I spent some time with them. I did a course, robotic course there. So now question is, what is robotic surgery? So I think most of you must have seen this one, but to clarify I will just show you this one. So here this robotic system has 3 components. So one first where surgeon is sitting, that is surgeon's console, where 3D visions will be there. And then comes this robotic arm, patient card. This is older system, and then comes vision card. So screen will be there where you can see very high definition intraoperative pictures. And these are finger controls in the surgeon's console, and whatever way you move your fingers, that your instruments are going to move in a similar way. So this is a master-slave system. This robot has no autonomy. So whatever surgeons does, that has to move accordingly. So these instruments have 7 degree of freedom, that is more than your finger or wrist. So here you can see whatever way you are doing your surgery, that your movement will be manipulated on the finger instrument tip, and accordingly that surgery will be performed. So what are the advantages of robotic system? This has 3D and magnified vision. Instrumentation has 7 degree of freedom. So that's very mobile, that can move in any directions. And precision, very precise movement will be there. Tremor can be filtered. And articulation, it's very good. And ergonomic for the surgeons, because you have to sit in the surgeon's console. You don't have to strain your shoulder and neck. So what are the approaches for remote access robotic or endoscopic thyroidectomy? So these are the main approaches. So there are other approaches described, but these are the popular one. So first one is axillary transaxillary approach. The second is breast axillary approach, that is called BABA approach. Third one is retroauricular or facelift approach, and fourth one is transoral approaches. So transoral now becoming popular in Western countries, because their axillary approaches had been banned due to brachial plexus injuries. So all these remote access thyroid surgery, how do you make working space? Because until unless you make working space, you are not going to perform the surgery, you are not going to mobilize the thyroid lobe. So there are two systems. So one is a skin lifting system, where you give remote access incision, you raise a flap. In this case, this is retroauricular approach, so you give incision behind the ear and in the hairline, and raise sublatissimal flap from there, and then put this self-retaining retractor, and that will lift up your skin flap, and that will give you a space. The other method is CO2 insufflation, like laparoscopic surgery. Here you put the port, you connect with CO2 gas, that insufflate, and that creates a space there. So what are the indications? So these are indications for the beginners. So it should be, nodule should be less than 4 centimeter. There should not be any extra thyroidal spread. Lesion, ideally, initially it should be benign lesion or low risk differentiated thyroid cancer. There should not be any neck nodes, and patient should be motivated, because main advantage is to avoid a scar. Other advantages are also there, but these are the main advantages. But once you gain experience, you can do more and more complex cases. So is neck scar important in our oncological practice? These are 3 scenarios. So case 1 is 22 years old newly married female, and her marriage was at stake due to her thyroid nodule. The second one is 16 years old girl, parents were worried about her future. And third one is 25 years professional, she did not want any scar in the neck due to professional reason. So this lady, 22 years old newly married female, presented with swelling in the neck for 1 month time, and that was noticed in the in-laws house. And then there was a crisis, because they were blaming her as well as her parents, because they thought they had hidden this information. So when they came to ultrasound, showed around 3.6 centimeter well capsulated hyperechoic to hypoechoic lesion, and FNA was follicular lesion. So it was some chances of malignancy as well. So after counseling, considering all conditions, I offered retroauricular endoscope assisted hemithyroidectomy, because lesion was not confirmed malignancy, and at that time I had no access to the robotic system. And these are intraoperative pictures, and you can see the recurrent laryngeal nerve. You can identify and preserve the recurrent laryngeal nerve. So basis, like all basics of thyroid surgery should be followed, whatever way you are doing, whether you are doing open surgery or you are doing remote access surgery. And here you can see this is immediate post-op pictures after closure of the wound, and when I confronted patient's relative, in-laws, when I told ki everything was done according to the plan, they smile returned on their faces. And here you can see this is pre-op, and the second one is post-op after around 4 weeks time, and you can see this all neck looks beautiful and perfect. This is lateral pictures, so you cannot find the scar, that is well hidden behind the ear as well as in the hairline. So everything is hidden. This case 2 is 16 years old girl, and she presented with 3 centimeter nodule in the left lobe of thyroid. You can see the nodule, and FNA was that was papillary carcinoma thyroid. So we planned total thyroidectomy with left central compartment clearance with robotic system. And this is again, this is intraoperative pictures. So this all are like docking has been done, and then all the dissections, and this is surgeon console what I was mentioning. And this is, you can see this was the pre-op, and the second picture is post-op. So you can't find any scar, and this is the lateral picture, that lateral scar, that retroauricular scar is also well healed and well hidden. The third case is 25 years old unmarried female. Her marriage was planned after 3 months, and she came with right-sided right thyroid lobe nodule with right neck node, and that was positive. So in this case, we planned for robotic total thyroidectomy with right central compartment with right neck dissections, all through retroauricular approach. And this is a clip. So you mark the incision, you give incision, you raise the skin flap over sternomastoid fascia, you identify the external jugular vein, interior jugular vein, then you dock the robotic arms, and here this was old system, so here harmonic scalpel is there. So with the help of a harmonic scalpel, you can divide the vessels, you can hemostasis that can be achieved with the harmonic system. So here, if extrathyroidal spread is there, you can take the muscles of that one. So here you can see this is superior thyroid pedicle that is being divided with the help of a harmonic scalpel. And then you come on the trachea, you can see this is the trachea. You dissect the thyroid lobe over the trachea, and then you come. So here you come on the isthmus, you divide the isthmus first, so that you don't have, you are sure that you are on the trachea, you are not going to injure the trachea. And then you come in the groove, you can see the recurrent laryngeal nerve there. So that is being dissected. You can take the central compartment node along with this lobe. In same sitting you can do, or you dissect the nodule first and then you do central compartment clearance. So these are central compartment nodes. So this is berry ligament area. So here you have to be careful, otherwise you can injure the trachea. So here the point is harmonic scalpel, active blade should be away from the trachea, otherwise that is going to damage your trachea. So here you can see this is the defect, you can see the nerve, you can see the parathyroid, and here you can see this is immediate post-op pictures, and this is after 2 months. So she got married after 3 months, and all neck you can see that looks perfectly normal. But there was a problem with retroauricular approach, because for bilateral approach, for good clearance that takes time, because you have to re-drape and OT time is longer, and sometimes in few patients this retroauricular scar can be a problem as well. So this transoral approach, so this is really scar-free approach, because whatever incision you give, that will heal after some time and nothing will be visible, no stigma of thyroid surgery will be remaining. So here you put 3 ports, one 10 mm and 2 5 mm, and this with the help of endoscope or with the help of robotic system you can do total thyroidectomy with this approach. Here you can see these are the incision site. So once it heals, there is no stigma of thyroid surgery. But again here also transoral approaches, there are limitations. Here because you are coming from above, so sometimes you can find difficulty with identifying the recurrent laryngeal nerve. And if Zucker candle tubercle is present and that is bigger in size, your life will be very, very difficult, because very difficult to dissect in this approach, Zucker candle tubercle. And if lateral nodes are there, you cannot do lateral neck dissections with this approach. Maybe you can remove level 3 or 4 glands, but not complete neck dissection you can do. The fourth one is Baba thyroid, Baba approach, that is breast axilla approach. And here advantage is in single docking you can do your total thyroid surgery, you can do neck dissections as well. The duration is operative time is less than the other approaches, central compartment clearance is good, and lateral neck can be addressed in the same setting. And here you can see these are the port site, so all are 8 mm except one, you can give 10 mm for assistant port, and this is intraoperative pictures. And here the best part is here your position is similar to what you do in a open thyroid surgery. So neck extension with the shoulder roll, and your hands are less than 90° abducted. So there is no scope for brachial plexus injury in this approach. And the other best part is you remove the thyroid gland specimen and block. You don't have to divide in the middle. So you can see on the right corner that whole of thyroid, total thyroidectomy specimen is intact, and that everything comes in one go. And here you can see this was pre-op incision marked, and this is immediately after closure of the wounds. So because these are very 8 mm port sites, so that will heal, and maybe after few weeks time everything will disappear. So I will show you a small video clip of how do we do this. So here position what I mentioned, that is like a normal thyroid surgery, and here you dock the robotic arms, and then you with the help of instruments, this is sublatissimal flap raising, and here you come in the midline, you separate the strap muscles in the midline, you come over the thyroid gland, and here you can see the nodule here, superior pole nodule. So here you can see the thyroid gland here, parathyroid gland here. So this one was, so here you can see this was inferior parathyroid gland, and you have seen the vessels as well. So parathyroid artery was going in that thing, and this is ICG. You can see the bright green color, so that was the parathyroid, superior parathyroid, and you can see the nerve here. Nerve is being dissected here. This is recurrent laryngeal nerve. So what I mentioned yesterday, superior parathyroid is superior lateral to the nerve, and inferior is inferomedial to the nerve. So you can see this recurrent laryngeal nerve, inferior parathyroid here, superior parathyroid here. Then you come on the trachea, this is berry ligament. So under visions you can you take all the thyroid tissue, and then you come to the left side. So left side again, you mobilize the left thyroid lobe, and here you can see this is your parathyroid, inferior parathyroid here. So everything, because this is under 10 times magnification, so even smaller branches you can identify and coagulate these branches. So here you can see this superior pole is coming. So this one is that your nerve will be here in this part, and your parathyroid, superior parathyroid is here. So what I am dissecting, this one is the parathyroid, and this one is the nerve, recurrent laryngeal nerve. So all the structures you identify and preserve accordingly. So here everything is with monopolar and bipolar cautery. So this is monopolar scissors, this is the Maryland bipolar dissector, and one is the ProGrasp, and that is the best part of this robotic system, that is not in endoscopic one. So that ProGrasp is like your assistant. So that whatever way you want to retract the tissues, you can do that. So orientation and put a bag and remove whole of this gland, and this is your specimen. And this is immediate post-op. So everything is all looks clean. So my experience, we have done till almost 83 lobectomies, out of 83 total thyroidectomy in 28 and hemithyroidectomy in 27, central compartment clearance in 17 patients, and neck dissection for thyroid cancer in 10 patients. So out of these 83, 68 by robotic approach, and mostly it was retroauricular approach, and now we have moved to more of a BABA approach for total thyroidectomy. So out of these, papillary carcinoma was the most common in 35, and age group wise, if you say, mean age was 29 years, and mainly it was female, all female patient, and mean tumor size was 3.1 centimeter, ranging from 1.6 to 6 centimeter also we have done. And console time, this is the learning curve, and here you can see after almost 24-25 cases, console time, that is the main operative time, that comes down from almost 200 minutes to almost 50 to 60 minutes. So with time, once you learn, you gain experience, then all your surgical times comes down. And this is for the normal side. Again, after around 15 to 20 surgeries, your console time on the normal side comes down to almost 40 minutes. Complications wise, this was not different from what we do in open thyroid surgery. So now not many vocal cord palsy, temporary was there, but all improved. And one patient had permanent hypocalcemia. And hospital stay, we admit 1 day prior to surgery, and maybe post-op day 2, we discharge these patients. And there are so many systemic reviews and meta-analysis confirming the safety of this robotic approach. This is meta-analysis by Pan et al., 5,200 cases, and they showed robotic thyroidectomy is as safe as open thyroidectomy, but it gives better cosmetic satisfaction than open thyroid surgery. This is another meta-analysis by Kandil et al., and he showed all the complications were similar except temporary hypocalcemia. And now with evolving, this technique is evolving, we now get less of hypocalcemia, because we know if you touch the parathyroid gland with your hot cautery tip immediately after using that, that is going to damage your parathyroid as well as the nerve. So now we are careful in not touching the parathyroid or recurrent laryngeal nerve immediately after using the monopolar cautery or bipolar cautery. What are challenges? Lack of awareness about remote access surgical options. Dissection of recurrent laryngeal nerve in the tracheoesophageal group can be difficult, like open thyroid surgery. And dissection of Zucker candle tubercle, if that is present, that makes your life difficult, because your nerve will be just immediately posterior to the Zucker candle tubercle, and your parathyroid will be there itself. And that makes your life difficult, because sometimes it looks like parathyroid. It's very difficult to separate the parathyroid gland for the Zucker candle tubercle. Patient has to pay 1 lakh extra for the robotic instruments. Operating time, obviously that is more than what open thyroid surgery takes. And lack of tactile feedback, because here tactile feedback is not there, but in the newer system they are going to come with tactile feedback. And lack of support from medical insurance, but now a lot of medical insurance companies have started giving for reimbursing for this robotic surgery. So present and future single port robotic system has come up in the Western countries, but not in India till now, because consumable cost, instrument cost are quite high for this single port robotic system. Robotic arms should be more thinner and slimmer than what it is right now. It's better than the previous one, but still it needs improvement. Better instrumentation, tactile feedback, and now they are also planning to come up with infrared camera system integration so that you can identify the parathyroid gland with just RFA infrared imaging system. So here you can see this started with the second one, and this single port is now in use in other countries, and now this is Da Vinci 5. So this is going to be more high tech, and that is going to be launched in future soon. So as I mentioned, this robotic system has no autonomy at all. This is a master slave system, so whatever surgeons do, robotic arms have to be followed the same movement. But with AI emerging, evolving of AI system, so that may be having more autonomy in future, and one day maybe now robotic arm with intraoperative ultrasound, CT scanner, MRI, everything is going to come in future. And one day with all AI, maybe robots will be all manning the operation theater and will be doing the surgery in future. So we don't know. If we are ready for that one, then obviously that is going to come. So to conclude, robotic endoscope scarless neck thyroidectomy is safe and feasible. There is no difference in complications in comparison to open thyroidectomy. Equivalent oncological outcome with excellent osmosis gives better patient satisfaction. None of these approaches are perfect. So that's why so many approaches are there, and it depends upon individual experience, limitations, and infrastructure. Needs improvement in instrumentation, techniques, and approaches, and in future integration of AI is going to make robotic surgery more autonomous. Thank you. This is my robotic head and neck team of SCG. So me, Dr. Dharmendra, and now Dr. Shawnee has joined in place of Dr. Dilly. These are anesthetists. I would like to acknowledge all these people who have helped me in learning this technique. Thank you.
Thank you, Dr. Sharan, for the beautiful deliberation last day and today. For the postgraduates, this is very important topic for you. Scarless thyroid surgery, this endoscopic thyroid surgery and robotic thyroid surgery. What are the indications? What not to do? What are the different techniques? What are the complications? What are the outcome? Thank you, Dr. Sharan, for the beautiful presentation. Thank you.
For postgraduate, I'd like to mention, even if you don't have access to these systems, you should be aware about what is happening at present, and you should be ready to adopt these techniques in the future once you get the opportunity. Thank you. Yes, sir. Total thyroidectomy around 3 lakhs rupees. So that is much cheaper than any of metro city in India. So Delhi it will be around 8 lakh, 10 lakh, but in Calcutta still we do 3 lakh or 3.5 lakh, something like that. Thank you.
Excellent presentation, Dr. Sharan.
Oh, thank you, sir.
Very beautiful eye-opener. I only wonder on your last comment, as you said, if AI comes in and the robots become autonomous, I wonder if we'll have a Frankenstein-like situation.
Not really, because surgeons also, there will be different category of surgeons.
Yeah.
So at least robotic system with AI, that will be having a common medium like mid-size, what will you say,
Still master-slave going on,
yeah.
Not totally autonomous.
Yeah, so not totally autonomous, but if it will be in future, that will be, because there's so much of
that is the future,
involvement.
Surgery, less and less surgeons getting involved.
Yeah, but obviously surgeon's job will be there.
Yeah.
That is
but
going
it
to
will be backseat. It will be backseat.
Yeah, so problem is like we should accept that one. So
Yeah,
if
yeah.
I want, okay, robot can do surgery on me, that's okay.
Yeah.
But that is going to take time. That is not like, okay, 2 years, 5 years. Maybe in future that is going to come, because like such rapid technological advancements are happening in the field of AI.
And
So obviously that is going to affect these surgical outcome surgical techniques as well.
I think we as surgeons will lose that tactile feel of surgery. I mean, that will be lost on many of the cases.
But we have to teach robot, otherwise they are not going to learn that. So
Fantastic, fantastic. Thank you
okay,
very much.
okay, thank you. Oh,
Is there a role of drain in this, all these operations? Do we have to put a post-operatively drain under dressing, or there is no?
yeah, so what we do is, like Bava approach, because your port side, one of the port side we just put drain, like what I showed in the video. So that small drain, that will be there for 1 or 2 days. Once it is less than 20 ml, we remove that one. Retroauricular approach, we just put here lateral part so that it is well hidden, and transoral generally drain is not put. Otherwise you have to give, because if you are doing transoral robotic, in that case one arm is coming through axilla only. So there you can put the drain. So generally I put drain, even if you have to remove tomorrow or day after tomorrow, but that makes you peaceful because you can sleep well in the night.
Okay, thank you, sir.
Okay, thank you.
Now I request Dr. Shorodip, Professor Shorodip, come to dais. 2 things left for you. I request Dr. Sharon, please, to hand over the memento to Professor Shorodip Rai. Dr. Sharon, please, to hand over the memento. Now I request Professor Datta to come to dais to hand over the shawl to Professor Shorodip Rai. He is also the MSVP of Government Medical College, Coach Bihar. Dr. Professor Shorodip Rai, HOD ENT, and MSVP of Government Medical College, Coach Bihar. He is a MBBS and MS ex-student of this college. Okay, thank you. Thank you, Dr. Shorodip.
Thank you, Rajiv sir, for this wonderful presentation. Now I invite our next speaker, Dr. Professor Radhesham Mahato sir, for his talk on setting up of head and neck practice in resource-limited settings. The chairpersons for this session will be Dr. Rajiv Sharan sir and Dr. Ashwini Verma sir.
এদিকে মোবাইলটা নিয়ে যা, এদিকে লাগাও নাকি? Or respected chairpersons, our seniors, colleagues, our students, ladies and gentlemen. Today's discussion all over the advancement of head neck cancers, instruments, all those things, but I will tell about the simple thing, how to develop, how to start head neck practices in very limited resources region or centers. So, Tapa, এটা একটু কইছে এটা কি করে বন্ধ হবে ওর শো করব না শো করব না তো কি করব তাহলে না এটা হবে না এটা তো হচ্ছে না এটা ঠিক আছে ঠিক আছে এটা পুরোটা ঠিক আছে
আচ্ছা ওটা সেকেন্ডটা আছে হ্যাঁ হ্যাঁ স্যার স্যার ঠিক আছে স্যার এখানেই আছে হচ্ছে আপনার হাইট প্রেজেন্টেশন ভিউ
okay so yes I have been working in this region of North Bengal from Raiganj to Siliguri North Bengal Medical College since last 24 years since 2001. So what happened when we started our practice in our districts, we got so many cases but very few centers or of ENT department used to perform this kind of surgeries. Only some centers of cancers or few centers in Kolkata they used to do, but in ENT department of our state most of the people were not doing this kind of surgeries. So I started my head neck career in the district of Raiganj district hospital since 2001. So where there is when I started my practice in North Bengal Raiganj district hospital, at that time there was no monitor. Our anesthetists were we used to put their hands on fingers on the pulse. No monitor, no ventilator, bamboo, and very few occasions used to get the diathermy. Under those circumstances we started our surgeries till nowadays we are getting all these things, but higher machines are not available in our institute, but those things are available. So my presentation is some kind of motivational presentation, motivational talk to our juniors who are posted or who are going to work after doing their postgraduate at the periphery centers. So you can do safe surgery in minimum infrastructures with nowadays what I used to perform in those days now available in all centers, in all district and sub-division hospital. There are monitors, there are ventilators, diathermies are there in all centers, but in our time, in initial time, it was not there. So nowadays we are getting more and more cases of head neck cancers, especially oral cancer, such a huge percentage in our institute, in Duars and hill regions and also from plains. So many patients are coming regularly. So how we will do, we are doing nowadays, I will maybe smokeless tobacco, gutka and khaini jarda. Government of West Bengal, they prohibited selling of tobacco containing gutka. But what people do, they purchase one without tobacco and another is only tobacco. They tear the leaves and they pour them and they take. This is the real picture in our society. So awareness is very, very, very poor. And supari, betel nut queen, this is some cultural habits, mostly in the Assam. They used to give you, when you go, you give the raw supari, raw betel nut and pan. This is the culture. So in Assam and northeast region, you get the more and more oral cancer in those regions. And carcinogen associated with oral cavity cancer, buccal mucosa, these cases are more region. Alcohol consumption, again in tea garden region, they are poorly paid, very poor people. They take alcohol and other things, more than they take rice. Also they take rice, small vegetables with small dal, they take huge rice. That is the culture. So nutrition is very, very poor in those regions. So maybe, and when there is consumption of alcohol, smoking and tobacco, the incidence of cancer is much more higher in those cases. And this nutritional deficiency may lead to mucosal atrophy and poor immune defense, increasing susceptibility to carcinogens. And late diagnosis is still present, though government has so many plans, but people come to us in very late stage. Almost all the cases, 90% cases come in T4 stages in our center. Lack of early symptoms, though in mouth, nose, nasal cavity, early detection is highly possible, but our doctors, our health worker who are working in the periphery, they are not aware for this. What is, I talk to our CMO and other administrator, why they are not giving this thing, head neck cancer awareness like immunization and maternity care. The people are multi-purpose worker, ASAs, they are going to door up in the villages. If they are aware, they can take the patient to health centers. Health centers doctors can bring to us. So this lack of awareness is very common. And misdiagnosis, ignorance. One is, though misdiagnosis is one thing, ignorance is, I don't say, but there is one people, they stay in a very remote place. They will come to North Bengal Medical College or Kishanganj Medical College. They need some career. One patient will come, they are daily workers. They will lose their money for that day, and who will bring the patient, they will also lose their money. And this is not one day program. They will come to us, we will give them a date, I will do biopsy, prove, other investigation, periodic checkup. This is a huge time is taking. So some government policies should be there, or some NGOs involvement, active involvement should be there to bring the patient in early cases. And stigma of so stigma is not now, this is a problem. Patient wants treatment, but there is some social or economic problem is there. Some maybe the genetic susceptibility and environmental exposure of pesticides. Tea garden again, they use pesticides, they have to work in the tea gardens, and there are so fruits gardens in the Duars and hill area also. And ENT surgeons, though there are so many sets increased, but most of the ENT surgeons, they try to settle in the cities. In rural areas, still the ENT surgeons are less in our country. And FNAC biopsy is available till our district level, but not health center subdivision, but district level it is. Endoscopy imaging facility. FOL, nowadays every ENT surgeons have FOL set. They can see the lesions. I think every ENT surgeon they have the FOL, but imaging, MRI up to all the medical colleges in West Bengal, even rural, they have the MRI system, and CT scan in all the district hospitals now available. And there is no oral cancer screening, especially high risk population in our state, there is no screening system. But our oral and dental surgeons must be trained regarding the early detection of this tumor. Patient first, oral tumor first go to them, then they refer, or patient come to us, and they must be trained. I told earlier, cancer patients often travel long distance, leading treatment delay. There is no career. Patient cannot come alone. They are illiterate. They don't know where to go, how to go. That is another problem in our region. Underreported. Cancer registry is very poor. In our hospital, only oncology department, they have the, but in our department, you can't do lack of our manpower. especially ENT surgeon and head neck surgeons play a pivotal role in combating the upsurge head neck cancers in rural India and hilly region and North Bengal. While tertiary care is important, district level, what we do in our medical college, Northern Medical College, if the district people, ENT surgeons are aware, they can also do this kind of surgery in our district patient. First, diagnose early. In every case, your diagnosis is very important first. Infect the oral cavity, look for leukoplakia, erythroplakia, non-healing ulcers. Use tongue depression torch only, routine only, 2 things will suffice to examine the oral cavity. When you examine the hypophysis, then ENT surgeons needed, but this can be done with our health worker and the general doctor, they can do. And document and reference suspicious lesion, we have to diagnose. Awareness campaign, community to be done, more and more camps, NGO, meeting with NGOs, meeting with government sectors. Build a referral and follow-up network, lacking nowadays. Strengthen surgical capacity in these districts and train the next generation. For that reason, we come here. Assessment is very important first. And available human resources in our districts, what you need? You need few things, ENT surgeons, anesthetists, OT, nursing staff, ward. All these things are available everywhere. In spite of this, you can take help of your general surgeon colleague, your ENT colleague, you can take help of your orthopedic surgeon. Sometimes bone cut is not available, in, cannot be done by ENT surgeon, you can take help them, they will do. Operation basic ENT surgical instruments are everywhere. Stakeholders involvement. Initially, first resistance will come from your anesthetists because they are not aware of this kind of surgery. They are afraid of complications. If there is any complication, they will stuck in the hospital for hours. For that reason, they will discourage you. But start with small cases, gain faith of anesthetists, then they will start bigger cases, then they will give. And for your MSVP, superintendents, principals, and all those stakeholders, discuss with these cases. Human resources are available in all district hospital. Start with small cases, then go to the advanced cases. What is important, when you start a cancer case in your district, what problem you occur? First you face, the patient will not accept the thing. Make a board, discuss, 2 or 3 senior doctors, other department doctors, anesthetists, if the pathologist is there, make a team. And if the patient is illiterate, some literal family members should come or discuss with you, or if they are not available, involve NGOs. In district, I used to talk to the NGOs. They have a pivotal role. So discuss before starting. Sartorius started to discuss about the procedure, possibility of treatments. If they can go to our center, if they can go, our hospital has this kind of facility, we can offer you. If they agree, then document and start treatment. That is one thing. If the radiologists in our institute would do every Wednesday head neck tumor board, ENT surgeons, radiotherapy departments, pathologists, and patient parties, they come, we discuss together. With this, the patient referral system will be less. We discuss on the spot and we plan the treatment, and if we plan for surgery, we take the patient, or if we don't plan, they will go to palliation or other treatment. If they want refer, we can refer the patients according to them. But discussion must be there. Post-operative care, dedicated recovery area is less. In our hospital there are 10 beds, in districts there are no bed. So our ENT surgeons have to spare more time in the ward. First few hours, evening rounds twice, like that. Observation of vital signs, train your nurse in districts. In our hospital, there are postgraduates are there, but in districts, train your nurses. Emergency ARM bleeding management, referral, clear criteria, large tumors don't start, extensive vascular involvement, tracheal esophageal expansion, refer those cases. Record keeping, try to record of your own. Documentation, I told the discussion you may, when you discuss 1:1, then video clip must be kept. Otherwise patient will tell डॉक्टर साहब हमको बोला ऐसे लिखने के साइन कर दिया हमको समझ में नहीं आया. Their own language, talk to them, take some video recording and keep it with you. If a patient is all right, there is no problem. If there is any complications, then so many people will come. Then we can say. Further, counseling is very important. Monthly audit, photo documentation of the and video documentation of your surgery for legal purpose and for teaching purpose and for your improvement also. What difficulties and deficiencies felt in that surgery, how to improve for next surgeries. And community engagement is very important, I told earlier. To perform head neck surgeries, minimal setup surgeon, especially in a district resource limited hospital, must strategically adapt techniques, instruments and workflow to prioritize safety, efficacy and cost effectiveness. Surgeons start with procedures, I told earlier, small cases start. Avoid complex cases initially. Gradually you go. Initially, FNAC biopsy must be done up to all cases in up to subdivision level. Block hospital must refer the case. Excision superficial tissues and superficial like lipoma, CBCS, everybody does. Branchial cyst, branchial fistula, tracheostomy. Till now, all the districts they are now doing, they are referring. Tracheostomy must be done in district. We are getting so many severe standard cases in our institute because they are not doing. This should be done. Submandibular salivary gland excision. Try to preserve vessels. Simple thyroid lobectomy. Don't go for. Yeah.
Train your nursing staff to take care of your tracheostomy.
Yeah.
And most important thing is, especially for those kind of cases what you are doing, so better to use double lumen tracheostomy tube so that they should be trained. Even if some block is there, that inner tube should be removed and that should be taken care of.
Look, yeah, I told I have one experience. I performed one laryngotracheoplasty, put stent. And at the time, Raiganj district, there was no ICU, so-called ICU, but one special observation was there. The patient was gasping like that. The nursing staff, at that time there was no mobile. They go to booth, telephone booth and called me. I came immediately and removed the tube. So nowadays we train our nurses, up to nurses, to change the tracheostomy tube in our ward. PGs are always, PGs interns are always in our ward. Nurses we train. In our district hospital we train nurses also. That is very biggest problem. Blockage is visible because they don't suck properly. When you advise sucking, there is technique. They just superficially suck. They don't go too deep. So suction is also very important in tracheostomy tube care.
Double lumen will.
Double lumen is not a very, that is costly effort, but government are not supplying, but that is better. That is, double lumen is better tube. Supply is not, government setup is not, it is costly. No, so many, all the patients, they don't have money to come to our institute, they can purchase. If you, doctor can purchase, okay. Okay. Doctor can purchase. Okay.
Yeah. So in wholesale, I think that cost will come down to almost 1,000, 1,500 something. So in that case, that will be useful because that is a life-saving procedure.
In medical college, it is not problem. Periphery, it is the problem.
Actually, I have seen that patient is coming with single tube, intubated for months together. They are not changing their tubes, endotracheal tubes. They are putting them just, I have seen multiple patients I am seeing at Bihar Sharif. The patient has put their tracheostomy for how many days? Sir, 1.5-2 महीना से है sir, 3 महीना से.
So for tracheostomy.
So for that reason, if it is cuffed one, then that will be very problematic because patient is going to die with blocked tube. But if it is non-cuffed one, so still patient will survive with that one because even blocked tube patient can still breathe that.
For that reason, what
problem will be aspiration because if you are doing tongue surgery and all, then it will be a problem.
Now the problem of the tracheostomy tube care, what we do in our institute, we train all the PGs, change the tube on regular basis.
That is the most
regular. In the morning, first work is change the tube. Why? If there is blockage, if there is granulation, bleeding, so there is possibility of suprastomal granulation, stenosis is more. In our poor country, we don't have so much money to purchase a new tube regularly. What I do clean the tube, pour one दूध का डब्बा जो होता है, milk can small, steel वाला, साफ करके उसमें boil करके रखो and change the tube with the next day. When we discharge the patient, we follow and instruct the patient same protocol. They change the tube of their own, then they will go to home. That is our protocol in our institute for tracheostomy tube. We follow. We train every patient party. These are available everywhere. And go light. Headlights no, but top light is available now everywhere. Electrosurgical unit also available. In our time it was not present. Pre-positioning you get. Dissection, whatever I told yesterday, I usually do not put diathermy on the skin because there is possibility of hypertrophic scar on those cases. And so on for diathermy. I do dissection with blade, sharp blade. The hypertrophic scar, keloid formation will be less in those cases. Ligature is available, blunt dissection goes. Basic labs are available. Nowadays, in our institute, frozen section facility is there. We can send the frozen section sample. In North Medical started pathology department. These things are available now. Autoclave is available everywhere. Informed consent, what I told earlier, we should take. Risk of bleeding, injury, nerve injuries are told we should take for every cases. Photo documentation, optional, not optional, we should do. We must do. In every case, you delete after 3 months, but take photograph of all the cases, preoperative, paraoperative and postoperative, in every cases. So checklist summary for good operative outcome, correct diagnosis and imaging, informed consent and explanation of risk, pre-op fitness and optimization. Anesthetic checkup is must. What you cannot see, anesthetic can see this is the problem. Checkup is must, we do. Good lighting and sterile technique. Don't put your hand on head or mask or with glasses. I have been seeing till now few people are doing, but don't do that. Try to sterile. Gentle tissue handling. Tissue handling must be gentle. Drain and layered closure must be in layered, and good monitoring post-operative. Immediate post-op is very important in head neck surgeries, and histopathology follow-up. In histopathology, when you do neck dissection, sampling of neck dissection must be done, and patient education and scar management to be done. what will do? Mistakes. What will do? Incomplete consent. बोल दिया हो गया, ऐसे नहीं, लिखना है, बोलना है, डॉक्यूमेंट करना है, ठीक है. Inadequate hemostasis. Sometimes small vessels collapse during surgery. So when you find there is a vessel, take care at that time. Don't keep them, they will do later on. Otherwise they again reopen and you will be in problem. You will go at home, you will be problem. Poor nerve identification. Try to identify the nerves. So anatomy knowledge must be there. What they are doing in this meeting, cadaver dissection, go to your in district, go to your postmortem department, spare some time with them, then you can go do the neck dissection, all those things. Ignore sterilization, must starting complex cases early में मत करिए. Head neck surgery in district hospital is not a distant dream. Realistic and life-saving service that begins with basic infrastructure, skilled hands and committed heart is very important. You have to do that. जिल हमको करना है तो कर सकेंगे. फिर हमको देखना है जे I need this thing, this thing, this thing. There are so many excuses in favor of doing, and there are so many excuses not in favor in your doing. So must be positive for the treatment. Empower primary cases, surgical access, save lives with timely and safe intervention. Inspire others to serve beyond their comfort zone. It is very 22 or 25 years old. This is total laryngectomy done in 2002-3, I think, almost 20 years back, 22 years back. So this is very poor people. As just did total, they did not have money for radiation to come to Northern Medical College. So the patient 6 years, but she died with other complications after that. This is again the lower lip involvement of gingivobuccal sulcus. We did the marginal mandibulectomy and excision. This case, I know I tell the name, but he get the consent. He's the Badre Alam. Manado sir knows him. At that time, I was posted in Siliguri District Hospital. He has some heart problems like that. He was roaming so many places in Kolkata, medical colleges, everywhere. Some NGO took to me. I told them there is risk. I told my anesthetist personally, we did wide local excision and repaired nasolabial flap. The patient was doing very well initially. After 1 year, he got the radiotherapy. After 1 year, the patient missed follow-up and came again with this kind, with maggots. Same patient. So what we do, dressing, involve mandible and upper alveolus. वो हमको करना है तो बोल डॉक्टर साहब जो करेगा करिए. ठीक है. So we did the neck dissection, we did hemimandibulectomy, partial maxillectomy and put pec major graft for this patient. And the patient is still surviving. It was done 2014 and 2015. He missed follow-up. One day on the road, he called me, doctor. I told he was living in a slum area. In COVID, after COVID, I did not give him. I afraid to call him. Our PGs have their number. And last year, when I was going to a bank as for association work, he was calling me. He is the man. So when God save you, nobody can kill you. We are just mediator. We just do some our work. This is a huge parotid tumor. I was posted in Raiganj District Hospital. This patient was roaming in the hospital regularly in surgery department. They are not doing. What I told, what happened? हम रोज आता है कोई नहीं करता है ठीक है हम करेगा चलो. He has no money for doing FNAC in the hospital. There was no facility. He has no money for doing CT scan also. So we did. The patient survived for more than 10-15 years, and no radiotherapy, nothing. But after this surgery, I requested one or pathologist colleague, he did biopsy without cost. There was adenocystic carcinoma, patient survived for a long time. This is 2002 or 3 cases. So districts can be done in district hospitals. This is again maxilla, it was done in district hospital. This is early stage oral mucosa, just excision and supraumbilical excision. At that time I used to give the split thickness skin graft, the very good result in that case. So exposure is much simple. In this place, if don't split the lip, it is difficult to give a safe margin. If necessary, split skin. If you experience like Saran sir, you may not, but initially you should split. I still do. Posterior lesion, I do split lesion, split the lip. So you can approach whole tumor was free of margin, the patient was doing very well. This is again history in this case. I was posted Raiganj district hospital. The patient, he was a patient of Panjipara near this Kishanganj. He went, one person took to me. I was told that first we need, he registered for radiotherapy in MGM Medical College at that time. I told, go to tell them they will postpone your radiotherapy for few months. I'll do surgery then. No, doctor sahab, humko sab jaan pehchan hai, kar lega udhar aise. No go, I repeated, he did not go. I operated marginal mandibulectomy, the T3 growth, rectal type is involved, and the patient was doing well, split thickness graft. Immediate post-op, I sent him for radiotherapy in MGM. They scolded him and threw him. Again he came to me, he was crying, they are not giving him radiotherapy. I sent to Kolkata, ENT department, radiotherapy department. Radiotherapy department sent to ENT department. ENT department told there is a whitish thing, tumor was not removed properly. I chased them again. There is plastic surgeon Dr. Gautam Guho, ENT plastic, you must be knowing. I told and explained him. He went the patient to Gautam Guho. Gautam took the patient, Dr. Amitabh Rai, professor at the Medical College. He received full course of radiotherapy at that time. The patient was all right, around 19 years or so. Last year he died of MI. So this is the fact. This is again oral mucosa, angle of mouth, nasolabial flap would be constructed. This patient again history. T2 growth, tongue. I took biopsy, squamous cell carcinoma. I operated, sent the specimen to pathologist, report there is no malignancy found. I was new at that time in Siliguri district hospital. I called the pathologist, what he tell, maybe you remove the whole thing in the biopsy. I'm not the newcomer. I'm doing for a long time. Don't talk like this. You do twice or give me the specimen, I will repeat the biopsy. I talked with that tone. But that was insulting to me. He insulted me. That is, you have removed the tumor first on biopsy. Then next day, he rang me a big shot, pathologist big shot. So initially you face problem. So then he told me, send the patient party. The supplementary report is ready. If cancer is present and initially happens. If the people may not be knowing you, around 15 years back, people will behave like that. You have to change. If you are a right track, challenge there is no obstruction, challenge everyone. This patient, I had only problem, patient living. I cut with the diathermy margins. Had the neuralgic pain for 5-6 years, this patient. Nowadays, I am not using diathermy on tongue. I do with scissors and scalpel. Neuralgia for so many years, that was the only problem. Again, there is submental flap. Is oral mucosa, submental flap is doing well. This is huge parapharyngeal tumor. neurofibroma. That is also in Raiganj around 20 years back. No instrument, no oscillating saw. We have to split the mandible. I called the orthopedic surgeon. हम करेगा चलिए. So we splitted the mandible. We removed the tumor, and at that time plate was not available. We sutured with the wire. The patient was doing it. So करना है. This is again history. There are so many history comes. This is a case of chronic gutka chewer, trismus, oral mucosa cancer. So we prepared the patient. Tuesday posted for OT. Monday morning he told he has 2 marriages, I think. One at Delhi or one in Siliguri. Siliguri is unofficial, Delhi is official. So he had the problem, the court case, divorce last date. He has to go. I told, go, come by evening. Okay, sir, I'll go. Blood is arranged, everything arranged. He did not come. After 4 or 5 days, he will come for after 2 weeks. Again, he came with the political persons. You know what they did. And the reporters are also there. Reporters very supporting to us. They publish so many things, our services to and send to our community. So this is the fact. You don't know. They are telling doctors are not admitting you. Still, the patient, we forgave him and we operated submental flap. Submental male patient, what will face? Initially, there will be some hair growth, but the hair will not get the environment. The hair will be lost within 1 month or 2. And after radiotherapy also, the patient mouth opening is good. Now I can also cannot recognize him when he comes. And this is again Dilmaya. He is again huge tumor. We removed the part of the mandible and whole tumor and PMMC flap, post-op follow-up. But this patient could not receive the full course of radiotherapy and chemotherapy. She developed tuberculosis. That reason we could not, 5 years, she could not survive for 5 years. Because in hill area nutrition is less, but tuberculosis is every common. But for immediate post-op for 1 year, she was all right. After that, she had developed tuberculosis. No later recurrence. Good uptake of the flap. And sir told yesterday regarding the complications. Without complications, who does the surgeries? Who performs surgeries? Complication होना ही है कुछ patient में, but not. You can minimize the complication, but you can manage the complications, but complications होगा. This is the flap necrosis, local flap. Again, this is severe trismus. If you do everything, still there is trismus. I don't know what is the cause, but trismus is there. Trismus is again direct complication. This patient again, Vishwanath, she had a huge growth, neoadjuvant chemotherapy. The tumor melted, small. We tempted for surgery, operated. Margins were free of tumor. All the margins are free of tumor. And immediate post-op, there are some anesthetic complications. 3 days he was under ventilation and could not be moved. After 3 days, we could remove from ventilation. We thought the patient is complication, he will survive. But after 6 months or so, developed infratemporal foci recurrence. But PET scan also did not show. Our histopathology free of tumor. I don't know what happened with him. The very unlucky patient, unlucky surgeons here. So the patient died very bad manner. Recurrence was very bad. Recurrence in the skull base area. But patient, we were very happy with the patient operating, but could not. Very healthy young patient was there. When the patient comes to you after surgery, after few years, that Dr. Sahab hum acha hai, it is most gratifying, most satisfying. And actually, our motivations, your administrator will not motivate you, your colleague will not motivate you, no one can encourage you. Doctors will not encourage you of an institute, but These are our motivations. They tell us to go ahead. These are the patients to tell us. So, at the end, our professor, our first teacher, Dr. H.D. Mukhopadhyay, most of you of ENT Bengal must be knowing, I was the last house surgeon. He used to tell 3D. If you have 3D, it may not be intelligent, you may go up to a level. You can do something. That is desire, determination, and dedication. If you have 3D, you can do up to a level. So desire must be there, dedication must be there, and determination must be there. Karna hai to karna hai. Okay, thank you very much for your. Where facilities are available, microvascular or so, we should take, but in our institute nowadays there is no vascular setup.
Thank you, Dr. Radhesham Mahato. Thank you, Dr. Radhesham Mahato, for beautiful deliberation, and he has nicely described the different aspect of the head neck tumors, and he has also elaborated the pitfalls, tumor board, everything. For the postgraduates, as per the NMC norms, the ensuing exam for the postgraduates, GR3, will be in the month of September, October, November of different Indian universities. So they must have one long case and two short case. Minimum, there will be a malignant case for the head neck. So they should be prepared with the line of aspect Dr. Radhesham Mahato already described. One short case, or you may get a long case for this postgraduate final exam, which is knocking at your door in the month of September, October, November. University Health Sciences is going to do in the month of September. We most likely have October, November, and other universities are likely to do that. So please prepare yourself. And thank you, Dr. Radhesham Mahato, for beautiful deliberation. He is my junior brother. I was with Professor H.D. Mukhopadhyay. He has nicely told 3D. Professor Mukhopadhyay used to tell us 3D. He was a stalwart in the ENT of Calcutta. People of Kolkata and West Bengal and other people also know he has a publication, a book also. Thank you, Dr. Mahato.
Sir, there is regarding the last patient, you are talking about the infratemporal fossa, that there is a recurrence. So, sir, I want your take also for a NSCT. This is very much controversial for oral malignancies. Is that the recurrence usually comes whenever what I have in my observation for the past 6 to 7 years, that those who have extensive mucosal disease not involving the bones, per se the tongue cases, NSCT has a very excellent response. Now the margin is very much quite difficult to ascertain. Now there's some group is saying we have to take the previous margins, some are telling we should take a new margin and assess. What I did recent cases which I showed in my slide is by a paramedian mandibulotomy approach, which is an extensive lesion of the tongue as well as floor of mouth. There's no body involvement of the alveolus. So there's a significant reduction, so resulting some organ preservation, and we are seeing the patient very closely. Even 2 years post-op, we are keeping that patient 1 monthly follow-up, so to ascertain the recurrence. Now but the problem of NSCT in a buccal cases involving the mandible or maxilla or going to the ITF is that whenever we give NSCT, the tumor may shrink in any direction. So there is a high chance of skip lesions anywhere which has been put. That may be at the ITF, they may be at the upper alveolus or maybe the lower alveolus. So that times whenever we assess clinically, we feel that okay, fine, there is margin shrinkage and we can go for a resection. But somewhere there is some skip lesions per micromets which we are not aware of, or maybe a poor quality MRI or CT doesn't help in picking up. So what is your take regarding this?
oral malignancy of T3, T4 would give post-operative radiotherapy in all the NECTs. And Dr. Sir.
So as such, that NACT, role of NACT is very, very controversial. That is not going to prevent your local recurrence as such, but yes, lot of patients like tumor size will shrink, so you will be able to achieve negative margin. But like for me, because I am operating lot of advanced cases, and if your tumor is in buccal mucosa, and if it is involving RMT, I am going for ITF clearance in these patients. And my series, local recurrence rate in ITF is very, very less. I have problem with distant mets. So I want to address distant mets in these patients, and I am proposing NACT to prevent distal mets rather than local recurrence. So if you do a good clearance, because problem is, even if your pathologist does not give a margin positive, but because you don't know how, like which pathologist is seeing what all margins they are seeing. So even if final histopath report is margin free, more than 5 millimeter, but still some margin can be positive. So in these patients, if RMT involvement, that is going to recur in ITF, and ITF recurrence is very, very painful for the patient. So if you are taking, because recurrence is going to happen in your medial pterygoid, lateral pterygoid, all temporal. Temporal is very less. It's mainly that region, pterygomaxillary fissure region. So if you clear that region, if you taking out all the soft tissue from that region, that will decrease your recurrence, because that is your margin will be compartment. You are going to for a compartment resection in that area, and that is going to decrease your recurrence rate in that ITF region. And yeah, so NACT, that role, like if patient is having ITF involvement, and if nodal involvement is not that much, so it's only T1, N1 or N2A, means N2B, in those cases, patient is going to survive, going to do well in future. If nodes are much, much more, if it's N3 or it's 2C, in those cases, patient is going to have distant mets rather than local mets. So if your margin clearance is good, then local recurrence will be definitely less. And regarding your trismus part, so that we face, all head and neck surgeons face this trismus issue. But here, if you reconstruct, if you give good soft tissue here in the buccal mucosa, that is going to decrease your recurrence. Yeah,
we do routinely, but in this case,
yeah,
whatever
so
I do.
problem with local flap is you don't have that much tissue to whatever is required there. So that is going to restrict your mouth opening. So that will give trismus in these patients.
One patient really see so much of
So in place of local flap, if you do PMMC with good skin pedal, that will decrease your trismus.
But lesion was only mucosal lesion in this case.
Yeah, because local flap, obviously, that tissue is not that much.
Tissue was
you are
less.
resecting much, much more. So that obviously that is going to restrict the mouth opening.
But there is severe trismus in this case.
Usually, if we go for a tensionless suturing as well as tensionless reconstruction, that is more than the defect. If you take a more size flap, for example, if the defect is 4 by 5 centimeter and we put a flap of 6 by 7 centimeter, so we can suture it, we can manage it inside, so that, but in future it gives a lot of room to prevent trismus. Post radiotherapy also. The more the loose flap, the more the better.
Yeah, one more trick is there. So because when I was in Tata, so I was seeing even with ALT and radial forearm flap, patient was having trismus. So I just noticed why these patients are having trismus post-op. So I started doing just putting bite block in the contralateral side till like full mouth opening, and do your insetting of the flap with wide mouth open. So that is going to decrease your mouth opening. And after that, my trismus rate are much less than what it used to.
Trismus is the first case.
So that mouth opening, just keep a bite block on the contralateral side and then insert your flap. So that will give extra margin to that buccal mucosa part, and that will decrease your trismus.
Even sir, osteocutaneous flap, for example, we are sacrificing a segment of the mandible. So most of the people are not sacrificing the temporalis part also. So for example, a segment of mandible are putting for an fibula. So what happens, since the postoperative area will have fibrosis, that also resulting in trismus.
Now in those cases,
but if we remove the temporalis and that part, though we are not resecting so high and putting a segment of that of the fibula, so still the patient will not have trismus.
No,
but if you don't address this part, so what happens is that even the trismus develop even putting a fibula, and the patient cannot. So the patient comes over here, sir, you have done such a good cosmesis, but I cannot open mouth. I cannot have food.
We have patients done by microvascular surgery outside other centers. The patient become severe trismus. So many cases recently we have seen. So our case, this is the
fibula problem is because post-op we don't tell these patients to do mouth opening exercise, and that decreases mouth opening, and once patient receives radiations, then all full trismus will be there.
Full trismus.
So you just tell these patients to do mouth opening exercises from the beginning itself. Yes. So that will decrease the trismus, and during radiation just make sure that patient comes to you in between so that you can assess how are like patients doing all these exercises or not. So that will improve your trismus part.
So for NSCT status, sir, we are only seeing for a mucosal disease only, having extensive mucosal disease to see a progression-free, that is a PFS, progression-free survival. So, but yes, sir, we have seen other than the RTUG trial for the tax 334, that yes, they give a little bit of progression-free survival with the TCF regimen, but that is limited to the mucosal disease, not for the RMT or bony diseases.
That is all controversial.
That is all controversial.
How you interpret those results.
But sir, what we are doing is that even if we give for a extensive mucosal disease, we go for a NSCT followed by surgery. When you are giving a concurrent chemoradiation, we take the previous field. We ask the radiation oncologist to take the previous field because we document the previous one prior to NSCT. So these are very controversial. Reports are yet to come.
Whatever, in some patients, you don't think that you can cure this patient, but but some easy cases they had the complications. The special biological immunity may be there, but some patients Badralam I showed. We did not have any faith. They did not think of cure. Just they told we operated. Dr. Datta was there at that time. So, but he survived. But in some easy cases, small cases, we are getting recurrences. That is the problem. We take care all those things.
Yes, sir. There are a lot of problems also come from outside. For example, we are getting some patients has been operated outside in any other places, and that came out to be a pathological.
No, we are doing. We are most of the cases. So we are our own cases.
We do not put for adjuvant radiotherapy. So we said, okay, fine. Follow up. You have a PT2N0. Now, after 1 year, they came with a neck nodal recurrence. Sir, you said a follow up. Now see it is a neck node. So then we are thinking that where the mistake has happened, because we are as per the protocol. So there may be something, they have left some nodes or something which happened. So this is quite unpreventable.
Something out beyond our thinking, something happens sometimes.
Regarding this Christmas, there is one very nice device.
I know. Maybe when the patient go to radiotherapy, they don't come to us.
What happens?
After severe treatment developed, then they come to us.
You call these patients in between.
Yeah. Initially the patient was good, but after radiotherapy,
what happens, you ask them to do some exercises, they ignore it. After some time, they stop. When the patient comes after 2 months, 3 months, the trismus would have set in. But if you give them the device, they will do it religiously daily. So trismus is less in that case. It is not totally.
We advise every patient.
Less. Yes. It should be continued long.
Yeah. All different. Yeah. Okay, thank you.
Why there is delay in diagnosis of head neck cancer? One thing I should mention, that India is a vast country and there are so many methods of treatment. Patient has many options. other than the modern medical treatment. There is Ayurvedic, homeopathy, naturopathy, magnet therapy and other indigenous system of treatment. So they come late to us and they refer the patient very lately to us. Particularly the homeopathy doctors who treat this type of case say the nose as a boil. First it will increase by giving this dose and then it fungus and they tell them that it will heal now, but it is too much delay. So there are so many system of indigenous system of
So awareness is very poor. That is the thing.
Awareness is
very poor.
and there is too much competitor for modern medicine.
The problem, sir, the problem.
And the language, multi-linguistic.
Language is not much problem in treatment now.
Yes, problem. And the
Is it
economy.
problem, sir?
Economy.
Language
the
problem.
patient you diagnose today for leukopellicia or erythropellicia, then he shifted to work in Kerala. The migration of the labor, and they ignore there. They are very much busy to send money to their family in the village. So this is a problem. Economy is also a problem, and that you said government will take. We should take CMH. I will tell it to give a thought to the health worker. It is not the work of CMH. It is the legislative assembly should take the decision. We don't make health policy. We only carry forward the health policy. And you told that West Bengal government, Gutka and other is separated. Why you are not telling that 20 rupees pouch is serving at the door for alcohol?
Thank you, Professor Datta. We please don't go for the controversy. Government of India is promoting mixopathy, so please stop the mixopathy and all these things. Yes, we go for the academic discussion only. Thank you, sir. Thank you.
But one important thing, one very.
We go for the academic discussion only.
Yes, sir, but
Not for the government strategy, policy, mixopathy, and all these things. Thank you, sir. Thank you.
Sir, there is one discussion.
This is not for the discussion for the mixopathy and all these things. There is parliament, the state government, this assembly. You please promote our political leaders for that. We are going for the academic discussion. Please limit us to the academic discussion, please.
Yes,
please.
So basically, sir, I just want to share one of my experience regarding the patient's belief. So the patient came with a dual primary. The patient is having a thyroid lump as well as a breast lump. So for the breast lump, I need to go for a core needle biopsy. So, but the patient had a fungated breast lump. So I didn't went for a punch biopsy because it will bleed. So I planned for a true cut biopsy, core needle. So when I put the core needle biopsy,
Hey, organizing.
Thank you, everyone. We'll have a short break of 5 to 10 minutes now, and immediately post that, we'll begin with our paper and poster presentations in Lecture Theatre 2. Our judges for paper presentation will be Monotosh Datta sir, Dr. B.K. Bhattacharjee sir, and Dr. Ashwini Verma sir. Judges. And judges for poster presentation will be Dr. Rakesh Kumar, Dr. Guha sir, and Shoradeep sir. Please stay back. The paper and poster presentation will be held in this same OT or LT. Gujri sir to kindly felicitate Dr. Rajiv Sharan sir. Thank you sir for your wonderful sessions.
Hello. Good afternoon, everyone. We are going to start with the paper competition. The judges for this would be Dr. Rakesh Kumar, Dr. Manotosh Dotto sir, and Dr. Barun Bhattacharya sir, our HOD. The first presenter will be, we'll start with the postgraduate trainee. First, we'll have Dr. Anmol. The paper competition, the total time duration is allotted is 8 minutes per person. The presentation time would be 6 minutes and the question time would be 2 minutes. At the end of 5 minutes, we'll have a warning bell to tell the participant that she'll have to finish the presentation within the next 1 minute. At the end of 6 minutes, we'll have the second bell, and after 2 minutes of questioning, we'll have the third bell. Thank you.
A very good morning to all of you. Today I, Dr. Anmol Kaur, is going to present a paper presentation on ameloblastoma across spectrum. It is a case series. First of all, introduction. Ameloblastoma is rare odontogenic tumors derived from odontogenic ectoderm. It represents about 1% of all the jaw tumors. They are second most common odontogenic tumor. They are benign, slow growing and locally aggressive tumors. Surgical excision is required for the tumor. Materials and methods. All the cases with pain and swelling over the jaw in Department of ENT in MGM Medical College are included in this study. 4 cases were included. All the cases had undergone hemimandibulectomy with Rechen plate reconstruction. First of all, first case. This is a 13-year-old male patient. Here is a pre-op picture showing the tumor in the left mandible region. CT scans were done which show the expansile lytic lesion on the left mandible. The intraoperative picture shows us the reconstruction being done with the plate, and this was the specimen taken out. The post-operative picture was taken and without any complications. The microscopic image is showing us the palisated columnar cells. This is the second case. This is a 33-year-old female showing the preoperative picture. The lesion is on right mandibular region. CT scan showed us large lytic lesion on right mandible with cortex thinning and honeycomb appearance. The intraoperative picture is showing us resection of the tumor being done from the right mandibular region. This is the third case. The 20-year-old male showing a pre-operative picture. The lytic lesion is on the left mandible. For the earlier cases, we had conduct CT scans. The intraoperative picture is showing us the resection of tumor and the reconstruction. This is the fourth case, a 24-year-old boy. The tumor was on left mandibular region. The CT scans were done, which shows us the multiple septa formation and honeycomb appearance. The microscopic image shows us columnar cells with reverse polarization. Discussion. Patients often present with the swelling in maxillary or mandibular region. Tumor and characteristics are assessed using the patient's history, clinical examination, and imaging, most commonly used with CT. Surgery for classic ameloblastoma is complete en bloc resection with reconstruction with Reckon plate, which is classified as segmental or marginal mandibulectomy. Iliac crest internal oblique free flap can also be used in mandibular reconstruction. Conclusion. Ameloblastoma is most commonly occurring odontogenic tumor of the mandible and maxilla. It is a locally invasive but slow growing tumor that presents with painless swelling of mandible or maxilla. The best treatment of ameloblastoma is aggressive en bloc resection with simultaneous reconstruction. The high recurrence rate and large tissue defects have been long-standing issues in the treatment. Thank you. Yes, sir.
What is the average age group?
Sir, average age group is 20 to 40 years with male predominance.
Male predominance.
Yes, sir.
Whether this been published in any journal or anywhere else?
No, sir. It's
Not
not
yet.
published.
Okay. What is the post-surgical picture you have not shown?
Sir, I have shown in the first case.
Yes,
In the
second, third, fourth, you have not shown.
Yes, sir.
The outcome was?
The outcome was, sir, without any post-op complication. We had no post-op complication in any of the patient.
Okay.
No, sir. No facial paresis. Thank you, sir.
Thank you, Dr. Anmol. Next, we have Dr. Davis from Department of ENT, MGM. पेपर वाला खोलिए।
ये मैडम का है ना पेन ड्राइव?
हाँ, पेन ड्राइव में पेन ड्राइव खोलिए।
एक मिनट में
ये छोटा वाला पेन ड्राइव।
इसका तोड़ने के लिए मतलब ये इसको म्यूट करवा सकते हैं। Good afternoon, respected panel and my fellow audience. Today I'll be presenting a paper presentation on thyroglossal duct anomalies encountered in tertiary hospital in East India. I am Dr. Davis K. Matthew, PGT second year in the Department of ENT in MGM Medical College, Kishanganj. Introduction. Thyroglossal duct anomalies is the most common congenital neck mass. It can occur at any age, mostly in children. It was a 17-case series in MGM Medical College, Kishanganj, and there was a strong procedure preferred, and there was no recurrence when we did it post-operatively. Thyroglossal duct anomalies arise from persistent thyroglossal duct. 75% of congenital neck masses are thyroglossal duct cysts. They are commonly midline and moves with deglutition and tongue protrusion, and they're diagnosed with USG and FNAC. Simple excision would lead to a high recurrence, and a cyst-trunk procedure would lead to a standard of care. The methods of the study were, it was a prospective study of 17 cases, the period being from March 2022 to October 2024. The setting was an ENT OPD in MGM Medical College. Evaluation of the patients were done by clinical examination, FNSC and USG. All underwent cyst-trunk procedure and follow-up until suture removal and beyond. The inclusion-exclusion criteria were, inclusion was midline cystic neck swellings diagnosed as thyroglossal duct or fistula. Exclusion was thyroid enlargements clinically diagnosed. Results were demographics. The key trends were in my study was sex distribution. Females predominantly presented with cysts, that was 9 cysts versus 2 fistulas, and males showed a high incidence of fistulas, that was 1 cyst versus 4 fistulas. A temporal shift, cysts peaked in 2023, that was 77.8% of annual cases, while fistulas became more prevalent in 2024, 80% of annual cases. Age patterns, pediatric cases that were less than 18 years of age, it comprised of 53% of all anomalies, with cysts being more common in this group. Fistulas more occurred more frequently in adults greater than or equal to 19 years, particularly males. So this was a gender distribution bar graph. So a thyroglossal fistula, it was most seen in males compared to females, and a thyroglossal cyst was seen more in females compared to males. And distribution according to age range, while coming to the smaller age group, that is the pediatric age group, that is 0 to 5 years and 6 to 10 years and 11 to 15 years, there were more predominances of thyroglossal fistula, and as we advanced more in the age group, we had thyroglossal cyst predominating. The investigation findings were, on FNSC, you had cystic or ductal epithelium with thyroid follicles seen. On USG, there were anoic cystic lesions with internal echoes, and thyroid profile was normal in all cases. Surgical approach, we did a cyst-trunk operation, and there was complete excision with central hyoid bone segment. Suprahyoid and infrahyoid tract was removed to prevent reoccurrence. These were some preoperative pictures. This was the pre-op picture in the side of incision, the excised thyroglossal. Post-operative outcome, there was no recurrence in any case, and patients were healed well post-suture removal day 7. Discussion. Thyroglossal duct cells are often most diagnosed. Differentials could be dermoid, lymph nodes, or cystic hygroma. Recurrence in our cases were 0% as series versus 2 to 10% globally. FNSA and USG are essential for diagnosis, and cyst-trunk remains the gold standard. Coming to the conclusion, thyroglossal duct cyst is a common congenital neck lesion. There is a female and pediatric predominance. Cyst-trunk operation is effective and safe, and there were minimal complications. No recurrences observed. These were my references. Thank you.
Whether this is published in any journal?
No, sir, it was not published in any journal.
Not yet.
Not yet, sir.
Post-surgical, after 3 months, 6 months follow-up, for the scars present in the girl child, you have recorded it?
No, sir. In these cases, we have not recorded, sir. It was just mentioned in the OPD cards. Like the scar line was healthy, or was there any scabs or gaping present?
In suprahyoid,
yes, sir.
What is the highest extension in your cases?
So we have
How
seen
much you have removed? What was the highest extension? In suprahyoid extension you have suprahyoid and infrahyoid.
Yes, sir.
So how much you approached?
So we go up till the base of tongue, sir, as much as possible, so that you can prevent recurrence.
In your series, how many cases you have gone to the base of tongue?
So it was done in 3 patients, sir.
3 patients.
Yes, sir.
And your recurrence was?
We have not seen recurrences, sir.
No fistula, nothing else?
No, sir.
How will you exclude? There is no thyroid. Only the thyroglossal cyst is the only thyroid present in that child.
So preoperatively, we do a thyroid function test, and we also do a preoperative USG to look for any other anomalous thyroid glands present than the normal thyroid physiological glands, sir, and we check.
How will you assess the normal thyroid gland is present in its position?
So we do a preoperative USG, sir, a USG scan of the neck.
If not present, the thyroid gland is normal. What should be the procedure?
If the thyroid gland is normal.
Not present.
Not present, sir. Then we check with the TFT, sir, and if the TFT reports are normal, sir, I think we can refrain from doing the surgery, sir.
Most of the time, thyroglossal duct is in the midline.
Yes, sir.
Have you encountered other places instead of midline neck?
No, sir. In this case series, I have not encountered anywhere else in the
What are
midline.
the probable sites of occurring in oral cavity or anything?
I didn't get your question, sir. Could you repeat?
Other sites instead of midline neck.
Yes, sir.
You encountered thyroglossal duct seed.
So in this series, I have not seen.
I'm not asking in this series.
Okay.
Just as a
More of it could have been present laterally also, sir. It can.
Have you gone through it? No.
Prank.
Thyroglossal duct cyst, any oral cavity, base, floor of the mouth.
No, sir. I have not seen much cases, sir. Okay, sir. Okay.
Okay, thank you.
Thank you, Dr. Davis. Next, we have Dr. Gurpreet Singh from Department of E&D, MGM.
Good afternoon, everyone, respected panel and my colleagues. Today I am going to present a paper presentation. Before we look into the first slide, let me begin with a simple question, simple truth we all face in the ENT practice. What often walks into our OPD as a routine polyp could be on histology turn out to be something far more sinister. This study was born out to that clinical uncertainty to decode what lies beneath these space occupying regions of the nose, sinuses, and the nasopharynx. Over 3 years, we carefully analyzed 180 such cases, and what we found reinforces the need for the sharp clinical suspicion and the absolute value of the histopathological confirmation. With that thought, let's move into the introduction. The nose, with its significant aesthetic and the functional roles, is commonly affected by both non-neoplastic and neoplastic lesions in the clinical practice. These lesions, ranging from benign conditions like nasal polyps to the malignant tumors, often present with the symptoms such as nasal blockage, discharge, and epistaxis. This study aims to categorize and compare the clinical and the histopathological patterns of the sinonasal and the nasopharyngeal lesions, enhancing our understanding of their incidence and the need for the accurate diagnosis and the timely treatment. The aims and objectives of this study was to explore the clinical and histopathological profiles of these lesions in a tertiary care hospital over 3 years. This retrospective study was conducted on 180 cases at a tertiary care hospital from May 2022 to May 2025. The demographic data, including age, sex, and the clinical symptoms, were collected from the histopathology and the OPD records. The study included medically untreatable cases of the masses in the nasal cavity, paranasal sinuses, nasopharynx, requiring surgical intervention. Histopathological examination followed excision or biopsy of the lesion was done. So these are my results. Out of the 180 cases studied, the males comprised of the 54% and the females were of the 46%. This near equal distribution highlights the widespread prevalence of the nasal and the nasopharyngeal lesions across the genders. So we observed that the most commonly affected age group was from 11 to 30 years for the significant portion of the total cases. The most frequent non-neoplastic lesion encountered was the inflammatory nasal polyp seen in the 91 patients. This was followed by the fungal infection in 10 cases and rhinosporidiosis in the 2 patients. Interestingly, 2 cases of rhinolith was also observed. Among the benign neoplasm, inverted papilloma was the most common with the 4 cases. Capillary hemangioma and the angiofibroma were of 3 cases, and a rare schwannoma was reported in the 1 patient. Regarding malignancy, squamous cell carcinoma was the most prevalent, reported in the 3 patients. We also noted 1 case each of esthesioneuroblastoma, rhabdomyosarcoma, and a round cell tumor. Though rare, these highlight the need for the vigilance in evaluating the nasal masses. In the nasopharyngeal subgroup, the majority were non-neoplastic, primarily adenotonsillar hypertrophy, seen in the 57 cases. 1 case of the non-Hodgkin lymphoma was reported to us. So, discussion, the study highlights the predominance of the non-neoplastic lesions, particularly nasal polyps, among the sinonasal masses, with benign lesions such as inverted papillomas and the capillary hemangiomas are also commonly observed. The malignant lesions, although rare, were mostly squamous cell carcinomas with a notable presence of esthesioneuroblastoma and non-Hodgkin's lymphoma. The findings underscore the importance of differentiating benign from the malignant lesions early to prevent the delay in the diagnosis and the treatment, with the surgical excision being the mainstay for the most cases and the close follow-up necessary for detecting the recurrences or metastasis. While concluding, the histopathological examinations play a crucial role in accurately diagnosing sinonasal space occupying lesions, enabling differentiation from a common inflammatory and infectious conditions, thereby guiding appropriate and timely treatment to prevent the misdiagnosis and ensure the better patient outcome. These all are my references. Thank you so much.
First slide. Previous. Sir, you are from which institute and your designation?
Sir, I am from the MGM Medical College and from this institute only, sir.
And you are?
From this institute only, sir, MGM Medical College.
Designation?
I am, sir, postgraduate trainee.
GR1,
GR3, sir, GR3.
Whether this is in published any journal?
No, sir, not yet.
Not yet.
Thank you, sir.
Have you noticed any patient presented with ear pain?
Yes, sir. In the cases of the nasopharyngeal subgroup, the patients were mostly complaining of the ear pain. About 30% of the patients were complaining of the earache. So that's why we have to go under the ear examination and do the autoendoscopy for them.
Yeah.
So that's also the another important aspect for deciding that whether it is a nasopharyngeal carcinoma or that.
So any patients of ear pain, you should, like persistent ear pain, you should look inside the nose.
Yes, sir. Yes, sir. For
do endoscopy.
Yes, sir.
Thank you, Dr. Gurpreet. Next, we have Dr. Gursimrat Kaur from Department of ENT, MGM.
Good morning, everybody. I am Dr. Gursimrat Kaur, and I am here to present a paper on the topic Fine Needle Aspiration Cytology versus Histopathology, a diagnostic consistency in salivary gland neoplasms. Salivary gland tumors account for about 3 to 10% of all the neoplasms in the head and neck region. They vary in type and behavior. Approximately 21.7% of all salivary gland neoplasms are malignant. FNAC is a minimally invasive and essential for pre-op diagnosis. Histopathology is considered as a definitive gold standard. The aim of the study is to correlate the FNAC results and histopathological findings. This is a prospective observational study which was conducted over a span of 2 years. The sample size was 30 patients and it was conducted in MGM Medical College, Kishanganj. We included the patients between the age group of 15 to 65 years who were diagnosed with salivary gland swellings. 30 patients who presented our OPD were clinically evaluated to be suspected cases of salivary gland swellings. They were sent for ultrasonography to evaluate size, shape, extent, and involvement of other structures. Then the patients underwent fine needle aspiration cytology. The cases suspected of malignancy were further evaluated and sent for contrast-enhanced CT scans. Respective surgical procedures were performed and the specimens were sent for histopathological examination. The gold standard for determining the sensitivity and specificity of FNAC was the histological diagnosis. After the data was put into Microsoft Excel spreadsheet, SPSS version 27 was used for analysis. To perform cytohistological correlation, relevant statistical tests were run. The results, first of all, in this study we included equal gender split, and majority of the patients were from the age group of 15 to 30 years, and the p-value was 0.0048, which suggested statistical significance. The gland involvement in our study, parotid gland was the most frequently involved, and it was statistically significant when compared with the involvement of the other glands. On FNAC, in our study, parotid gland tumors, 15 benign tumors were found, and 1 malignant, and 2 non-neoplastic was the finding. In submandibular gland involvement, 7 cases were benign, 1 was malignant, and 2 were non-neoplastic. Whereas in the minor salivary gland cases, 2 cases were of benign. Overall, we had 80% cases of benign nature, 7% malignant, and 13% non-neoplastic cases. On histopathological examination, we found 83% cases to be benign, 10% cases to be malignant, and 7% to be non-neoplastic. The benign tumor distribution was, as it has been shown in the table. There were 18 cases of pleomorphic adenoma, 1 case of myoepithelial, 1 case of basal cell adenoma, 1 angiolymphoid hyperplasia, 1 oncocytoma, and 2 cases of benign lymphoepithelial cyst, and 1 Warthin's tumor. Whereas we had myoepithelial carcinoma in 1 case and 2 cases of mucoepidermoid carcinoma. On correlating between the FNAC and histopathologic results, the p-value of 0.0009 and chi-square value of 10.9959, which indicated statistical significance in the relationship between ultrasound-guided FNAC and histology. The FNAC is highly sensitive, but specificity is limited. In our case, we found sensitivity to be 96%, specificity to be 33.3%, positive predictive value to be 92.3%, negative predictive value to be 50%, and overall accuracy was 89.3%. Our study showed equal gender distribution. In a study conducted by Vedula et al., he noted female predominance 46.6% were aged between 15 to 30 years, and similar age trend was seen in benign tumors across literature. The parotid gland was the most involved gland in our study, which was consistent with a study conducted by Elzeni et al. Pleomorphic adenoma was most common, which was also reported by Gudmundsen et al., in which he had 63% of the cases to be pleomorphic adenoma. The parotid tumors in our study were 94.4% benign and 12.5% were malignant, whereas a study conducted by Gudmundsen et al. Concluded 90.3% cases to be benign and 9.6% cases to be malignant. In our study, the FNAC performance results were the sensitivity was 96%, specificity was 33.3%, accuracy was 89.3%, whereas a study which was conducted by Almgadi et al. Revealed sensitivity to be 90.3%, specificity to be 100%, and accuracy to be 91.4%. In our study, FNAC missed 2 benign tumors and 1 malignancy in our institute. The possible reasons for the low specificity could be the overlapping cytological features between benign and malignant cases, low-grade malignancies appear relatively bland, and the salivary gland tumors often show mixed cell populations, the non-representative symptoms, and operator inexperience. I conclude my presentation by saying that pre-operative diagnosis is the key for early detection and timely treatment of salivary gland neoplasms. FNAC, when done by skilled pathologists, is a reliable, minimally invasive tool with 96% sensitivity. It helps guide treatment and avoid unnecessary procedures. However, due to overlapping features, diagnostic errors may occur, making histopathology the gold standard for confirmation. Ultrasound-guided FNAC may help avoid the false negatives. These are my references. Thank you. Sir, we have compared the results of FNAC with the histopathology to see how much we can rely on the FNAC results in the salivary gland neoplasms. But in our study, we found the sensitivity was very good for FNAC, but the specificity was poor. Yeah. So, that was it. So the take-home message for my presentation is that in a case of salivary gland neoplasms, it is better to go for an ultrasound-guided FNAC than the FNAC by palpation only. And the operator training, the operators who are taking the FNACs and making the smears, they should be well trained to improve the specificity, and the people who are reporting the FNACs, they should be well trained, so we can improve the specificity and solve the confusions between the diagnosis. Ji, sir.
And operated specimen, you have done histopathology.
Yes, sir.
And what is the result of histopathology, difference between the FNAC and open histopathological?
Sir, it has been presented in this slide, sir. This is the statistical analysis that we have done comparing both the FNAC and histopathology. Is better, yes, sir. That is the inference of our study.
Not yet been published in any journal.
It has been published by Curious in a PubMed Central Journal, sir.
Okay. The next slide. Why this your study and the next study of 8 patients, the specificity varies so high, was 33.3 and here 100%?
Yes, sir, that is what we have discussed. In our study, the FNAC, 2 benign tumors were missed and 1 malignant tumor was missed. And the possible causes could be the overlapping features of the benign and malignant cases in salivary gland tumors. It could be the low-grade malignancies. They normally show a bland features on the FNAC slides. and the salivary glands tumors, they often show mixed cell populations. It is operative dependent also.
Okay, thank you.
Thank you, sir.
Thank you, Dr. Gursimrat. Next we have Dr. Kavita Gupta, Department of Anesthesia, MGM.
Good morning, everyone. My topic today is ultrasound guided evaluation of airway, a comparative analysis with clinical parameters for predicting difficult airway. This study focuses on integrating ultrasound along with conventional clinical parameters to better predict difficult airway scenarios. So, managing a difficult airway is one of the most critical challenges in anesthesia practice. The incidence ranges between 1.5 to 13%, and failure to predict these cases can lead to serious complications. While clinical tests exist, they often lack accuracy and creating a need for better predictive methods. Problem statement: traditional methods are invasive or imprecise, need for improved accuracy in preoperative airway assessment, lack of standardized ultrasound-based screening protocols. Our primary aim was to assess whether integrating ultrasound-based airway assessments with clinical measurements can improve the prediction of difficult laryngoscopy and intubation in elective surgical patients. So we conducted an observational study over 6 months in a tertiary care hospital, including 100 elective surgical patients aged 18 to 60 years. Patients with known difficult airway, cervical spine issues, or other exclusions were omitted to minimize confounding factors. We use several standard clinical predictors, including Malampatti score, upper lip bite test, neck circumference, hyomental distance ratio, tongue thickness, and mandibular condylar mobility. These are widely used but individually have limitations in predicting difficult airway. The epiglottis is the hypoechoic space pointed out by the arrow. The mean distance from the skin to epiglottis is the average of the three measurements of A, B, and C. Here we have assessed outcomes using Cormack-Lihan grading during laryngoscopy and the intubation difficulty scale. Statistical analysis included Pearson correlation and ROC curves to evaluate predictive strength. We observed that higher Malampatti scores, larger neck circumference, reduced hyomental distance ratio, increased tongue thickness, and decreased mandibular mobility were significantly associated with difficult airway. The same thing that I have explained in the previous slide with the help of graphs is depicted here. This figure represents the performance of matrix of two models. Here the area under the curve for model 1 is 0.8, indicating a strong, whereas the area under the curve for model 2 is 0.7, indicating a moderate discriminatory capability of this model in distinguishing between cases of easy and difficult airway. The same thing was explained in the graph in the previous slide. In conclusion, combining the clinical and ultrasound parameters improves prediction of difficult airways. Although USG-based parameters show difficult predictive ability, it is not a replacement but a complement to the clinical parameter. These are my references. Thank you.
Thank you for presenting here. Thank you.
Next we have Dr. Pragya from Department of ENT, MGM.
Hello.
Good afternoon, everybody. I'm going to present a paper on demographics of branchial cleft anomalies. I am a first-year postgraduate trainee in the Department of ENT and Head and Neck Surgery in MGM Medical College. During the 4th week of intrauterine life, 6 branchial arches develop, out of which the 5th one obliterates soon after. The branchial arches are the embryological precursors of face, neck, and pharynx. Clinically, they can present as cysts, sinus tracts, and fistula, out of which cyst is an epithelial line structure that does not connect to the skin or pharynx, whereas sinus is a tract that connects it either to the skin or pharynx with a blind pouch, and fistula is an open tract that connects both the skin and pharynx. Branchial cleft anomalies account for up to 19% of all the pediatric cervical masses. First branchial cleft anomalies are caused by the embryologic duplication of the first cleft or first cleft and arch. It can present as an external fistula tract and is classified by work as type 1 and 2. The anomalies are purely ectodermal in origin and present as a cystic mass adjacent to the external auditory canal and is squamous epithelium but has no skin adnexa or cartilage in type 1, whereas in type 2 they may present as cysts, sinus or fistula in the region of the angle of mandible. They are ectodermal and mesodermal in origin. They contain squamous epithelium, skin adnexa as well as cartilage. Coming to the second branchial cleft anomalies, which are the most common, they present as cysts followed by sinus and fistula. Second branchial cleft sinuses are the most common and present as a congenital opening on the lower neck anterior to the sternocleidomastoid. The tract may communicate with the pharynx to form a true fistula. It has been classified by Bayes as type 1, 2, 3 and 4. Type 1 being the most superficial and lies along the anterior surface of sternocleidomastoid deep to platysma. 2 being the most common, lies anterior to the sternocleidomastoid, adjacent to the internal carotid artery and adherent to the internal jugular vein. Type 3 being between internal and external carotid artery, and type 4 lying deep to carotid sheath. Whereas the third and fourth cleft anomalies are the rarest ones. The third and the fourth cleft anomalies can be distinguished by the relation to the superior laryngeal nerve. The third cleft anomalies lies superior to it in the pyriform sinus, whereas the fourth one lies below it. In my study, I have done a retrospective study of 30 patients with branchial cleft anomalies managed and operated at MGM Medical College from January 2022 to June 2025, reviewed for age, gender, clinical features and presentation. This was a 6-year-old male with second branchial cleft fistula operated here. His histopathology is given here. We have found that there is 60% females and 40% males, showing a more predominance towards female. In age predisposition, we can see that 54% cases are in 5 to 10 years of age. In types, we can see that branchial sinuses are much more common than fistula and cyst. And in levels, we can see that the second branchial cleft anomalies are the most common, followed by first and then the third and fourth. Results. There was more female predisposition than males. The average age of presentation was 5 years, range being 5 to 10 years. However, their history dates back to infancy in most of these patients in case of branchial cleft sinuses and fistula, but in young adults in case of branchial cyst. Branchial cleft sinus and fistula are much more common than cysts, and the second branchial cleft anomalies are the most common, followed by first and the rarest being third and fourth. Therefore, in conclusion, we can say that out of the 30 cases, 60% were female, 54% of the cases were in 5 to 10 years age range, and 54% of the cases were branchial cleft sinus, 33% fistulas, and 13% branchial cleft cyst. The second branchial cleft anomalies are the most common, which was 67%, followed by the first, which was 67%, and then third and fourth, which was 6%. These are my references. Thank you.
You have the comparative data, your datas and our national by international level datas, comparative.
Sir, there was previously in a journal, in Indian Surgical Journal, in 2017, data was published from Mumbai TNM hospital. So I have taken reference from their data as well. But sir, I have not seen it published in any international journal up until now.
What are the national data and your data matches or differs?
Sir, sir, it matches.
Matches.
Thank you.
Thank you, Dr. Pragya. Next, we have Dr. Rohit from Department of ENT, MGM.
Good afternoon, everyone. Good afternoon, everyone. Respected panel and all my colleagues present here. My name is Dr. Rohit Bhattacharya. I am a first-year junior resident at MGM Medical College in Kishanganj. I am here to present a retrospective study on the excision of submandibular glands, the last 3.5 years of experience at our hospital. Submandibular gland excision is a diagnostic and therapeutic procedure for a variety of salivary gland diseases. Various indications for submandibular gland excision includes silolithiasis with proximally located stone in submandibular gland, chronic sialadenitis, submandibular gland tumors, benign and malignant, solid salivary gland masses of unknown entities for obtaining histological classification. Salivary gland malignancies overall constitutes 3 to 6% of all head and neck malignancies, out of which 11% are in the parotid gland, but there might be a higher rate of malignancy in the submandibular gland masses, which can be studied and evaluated on the basis of histopathological findings post submandibular gland excision. A brief introduction. The submandibular gland is the second largest of the three main salivary glands, including the parotid and the sublingual glands. The submandibular glands are paired with major salivary glands in the submandibular triangle. The gland has a superficial and a deep lobe separated by the mylohyoid muscle. The Wharton's duct, primary excretory duct of the submandibular gland, drains into the oral cavity at the sublingual caruncle, which is a papilla located medial to the sublingual gland and lateral to the frenulum linguale. Submandibular gland accounts for approximately 70% of the saliva produced in an unstimulated state. The submandibular gland develops after the parotid gland in the 6th week of prenatal life, originating from the epithelial buds surrounding the lingual folds on the floor of mouth. These epithelial buds develop into solid cords, which canalize to form the submandibular glands, the striated and intercalated ducts, which develop by 16 weeks, and the acinous cells predominantly by 24 weeks. The submandibular gland is located in the posterior portion of the submandibular triangle. Saliva production facilitates swallowing, digestion, pH buffering, and dental hygiene. The aims and objectives of my study. This is a retrospective study of 50 patients who were managed and operated for excision of submandibular gland at MGM Medical College from January 2022 till May 2025. The case records for all the patients were reviewed for age, sex, clinical features, and presentation. These are some of the intra images of a recent submandibular gland excision done in our department. When we study the cases in the last 3.5 years, we have operated 50 submandibular glands excisions, out of which 17 patients had sialadenitis, 21 patients had pleomorphic adenoma, which is a benign tumor, and 12 patients had benign cystic swellings. Out of all the three predispositions, for sialadenitis, there is 8 patients were male patients, and 9 patients were female patients. As we can see in the graph below, the male patients are represented by the bar in blue color, and the female patients in green color. There is a more predisposition of female patients, which we have operated here. For cases of silentinitis, more than 50% of the cases in for male patients are in the age group of 11 to 20, and in female patients there is more than 30% cases are in the age group of 31 to 40. The mean male age is 22.5 years, whereas the female mean age which was operated here was 42.23 years. For pleomorphic adenoma as well, we see that the male age and the female age coincides in the 3rd decade of life. Case records of total 50 patients who underwent submandibular gland excision were retrospectively reviewed and analyzed. The results obtained shows that there have been more cases of benign tumor growths or pleomorphic adenoma as we saw earlier of submandibular gland than silentinitis, which differs from normal epidemiological predilections. Normally we see that there are more cases of silentinitis in any tertiary care setup where submandibular gland excision is done, followed by benign tumors. Epidemiologically, the exact prevalence of silentinitis is unclear. There is no specific age and sex predilection for silentinitis, but as we see from our data, the mean age, male and female combined, ranged from 3rd to 5th decade of life with a greater female predisposition. In case of pleomorphic adenoma, which has an incidence of 2 to 3.5 cases per 1 lakh population, we find that mean age of occurrence is the 4th decade of life with a more female predisposition than males. Mean age of occurrence in females is also more than in males. Overall, submandibular gland excision is being done on a regular basis for pathologies such as chronic silentinitis, silolithiasis, benign and malignant neoplasms. Other indications for excision of submandibular gland includes siluria and other autoimmune conditions. Care must be taken while excising the submandibular gland, as there are chances of injuring the marginal mandibular nerve, lingual and hypoglossal nerve. These are my references. Thank you.
You mentioned the chronic silentinitis. Is there any relation, or you found any calculus within the gland or the duct as a etiological factor?
Yes, sir. Sir, mostly we see that there is a presence of silolithiasis along with silentinitis, and the submandibular gland excisions which were done here, mostly if the stone is present distally to the gland or more towards the intraoral cavity, we have tried to operate it intraorally as well, but the gland excision was done in case stones which were present proximal to the gland and obstructing the Wharton's duct and causing chronic inflammation in the patient.
You have a retrospective study of 50 cases, huh?
Yes, sir. In the last 3.5 years up till now.
Okay. Any endoscopic removal? Not.
No, sir. We have done all open submandibular gland excisions. Thank you, sir.
Thank you.
Thank you, Dr. Rohit. Next, we have Dr. Surbi Gupta, Department of ENT, MGM.
Good afternoon, everyone. I am Dr. Surbi Gupta, postgraduate trainee, 3rd year at MGM Medical College. Every thyroid nodule tells a story, but not all of them are dangerous. The real question is, can we tell the difference before it's too late? Okay, fine. Fine needle aspiration cytology, especially when guided by the Bethesda system, offers a powerful answer. Today, I present our experience in evaluating just how accurate FNAC truly is. brief introduction. Thyroid disease is prevalent in India with over 42 million affected, while thyroid cancer is rare. 8.7% out of the 1 lakh people annually. Palpable thyroid nodules are much more common. Fine needle aspiration cytology plays a pivotal role in the assessment of the thyroid lesion, guiding decision between surgery and the conservative treatment. The Bethesda system for the reporting thyroid cytopathology was introduced to standardized diagnostic terminology in the thyroid FNAC. It classifies lesions into 6 categories with associated malignancy risk and the management guidelines. This study aims to evaluate the histopathological correlation and the diagnostic accuracy of the Bethesda at the institutional level. Materials and the methods. An analytical retrospective study conducted over 2 years from May 2023 to May 2025, analyzing 80 thyroid lesions. Data was retrieved from the institutional database and cytohistopathological correlation was performed. Diagnostic accuracy of Bethesda was assessed using sensitivity, specificity, positive predictive value, negative predictive value, and overall accuracy. Inclusion criteria were thyroid lesion with corresponding histopathological diagnosis, while cases with incomplete data or inadequate samples were excluded. We observed a strong female predominance with 88% of the case being female. The most affected age group in our study was between 21 to 40 years, counting for the majority of the cases. When we categorized the thyroid lesion using the Bethesda system, we found that category 2 benign lesions were the most common. As we can see, 57 out of the 80 patients were the benign. We then compared FNAC finding with the final histopathological diagnosis. There was the excellent correlation, especially in the benign and the malignant categories. Now, we had a small number of the discordant cases which mostly arose in the intermediate Bethesda category, particularly in the category 3 and the 4th. Out of the 82 were the discordant. Analysis showed sensitivity of the 90% and the specificity of the 100 and overall diagnosis accuracy of 97.5%. These results underline the strength of the FNAC detecting malignancy with very few false positive or the negative. The sensitivity is the 90%, specificity 100, positive predictive value is 100 and negative predictive value is 96.77. Accuracy is very good, it's about the 97.5%. Now a discussion is, our study demonstrated a female predominance 88% in thyroid lesion, consisted with national trends. The most common age group was 21 to 40 years and the predominant lesion was non-cancerous goiter. Aligning with previous studies, the diagnostic accuracy of FNAC was high, 97.5%, with sensitivity and specificity of 90 and the 100 respectively, reinforcing its reliability for the detecting malignancy. To conclude my topic, FNAC remains a highly sensitive and specific method for evaluating thyroid lesions, with Bethesda providing excellent diagnostic accuracy for the detecting malignancy. All these are my references. Thank you.
You have ever done ultrasonography by your own in the radiology department? Have you ever done?
Yes, sir. I went to the radio department and I did.
I always advise the junior resident of ENT department to learn ultrasonography, particularly of the thyroid. It is the modern trend that a surgeon will do the ultrasonography and take the FNAC from the representative area. And always, sometimes, you know, the malignancy of thyroid is multicentric in origin. So, you may take several FNAC biopsy by different needle and syringe, not in a single syringe or needle.
Yes, sir.
It is also important. You have not mentioned the Hashimoto's thyroiditis.
Yes, sir. In atypical.
Autoimmune thyroiditis or lymphocytic thyroiditis.
Yes, sir. It comes into atypical ATP undetermined significance.
If we find Bethesda classification 4, then what will be your priority? Either USG guided, FNAC, or anything else?
Sir, biopsy. But follicular neoplasm, we can't decide by the FNAC only. We have to do biopsy. So because of the malignancy rate is also high, it's about the 30 to 45%. So we can't rely on only the FNAC. That's why the discordant 2 cases were in the grade 3 and the grade 4 only.
Thank you.
What kind of biopsy you will do for Bethesda 4?
True cut biopsy.
What are the
Excisional.
pathological factors that will decide whether lesion is malignant or non-malignant in Bethesda 4 lesion?
Sir, we have to take a basement membrane because the basement membrane only can decide it is the malignant or not.
That is for normal cancer.
Yes, sir.
Okay. For Bethesda 4, there are 2 criteria. What are those 2 criteria? Capsular invasion and angio invasion.
Yes, sir.
So even if you do true cut biopsy, you are going to take only a small piece of tissue. You have to see whole of the tumor for angio invasion or capsular invasion. So biopsy is not required for that one. You have to do hemithyroidectomy at least for diagnosing these patients.
Okay, sir.
Okay, so biopsy is not recommended for Bethesda 4 lesion. That if you want to confirm, then you have to do hemithyroidectomy.
Hemithyroidectomy. Okay, sir. Thank you, sir.
Okay, thank you.
Thank you, sir.
Now our last participant for the postgraduate trainee category, Dr. Survi Malik from Department of ENT, MGM.
Good afternoon, everyone. Today I'll be presenting a poster on the topic Study on Open Conventional versus Microscopic Parotidectomy. I am Dr. Surbi Malik, postgraduate second year from MGM Medical College. Parotidectomy goals. The parotidectomy goals are complete tumor removal and preservation of the facial nerve integrity and function. Surgical planning depends on the lesion size and location, that is superficial versus the deep lobe, tumor nature, whether it is benign or malignant, and its proximity to the neurovascular structures. What are the surgical techniques? Open versus microscopic. Open conventional parotidectomy, it is a gold standard. It gives good access to large or infiltrative tumors. What are the drawbacks? Visible scars, more tissue disruption, and higher facial nerve damage risk. Microscopic assisted parotidectomy. Enhanced visualization and magnification, better nerve preservation, fewer complications, and improved cosmetic results, ideal for selective benign tumors. Study objective, compare 20 cases in the Line Seva Kendra, analyze objectives, nerve function, complications, rates, and recovery. Evaluate evolving role of microsurgical techniques. Study design and patient profile. Prospective case series. In the Department of ENT at Line Seva Kendra, 20 patients were taken from the age group of 4 to 65 years. Selection criteria was based on the clinical, radiological, and cytological evaluation. Includes pediatric and adult patients. Pre-operative evaluation was done. History and physical examination was done. Ultrasound and contrast enhanced MRI was done, and FNAC was done for the patients. Surgical approach, open, conventional or microscopic assisted, depends on the lesion depth, proximity to critical structures and surgeon preference. Superficial parotidectomy for superficial or non-encasing lesions, and total conservative or total parotidectomy for deep or parapharyngeal tumors. Technique. Facial nerve identified using anatomical landmarks. No intraoperative nerve monitoring was used. Microsurgical cases was done using operative microscope. Post-operative monitoring. Facial nerve was graded by House-Brackman score, evaluated for nerve function, cosmetic outcome and complications. Adjuvant therapy given in malignant cases. Data analyzed for outcome comparison between approaches. These are the series of 20 cases which were operated in our institute, which includes a pleomorphic adenoma, basal cell adenoma, mucoepidermoid carcinoma of high grade and low grade, hemangioma, branchial sinus and lymphangioma, which were operated by different techniques of superficial parotidectomy, total conservative or total parotidectomy. So some of the representative cases are: a 4-year-old child presented to our ENT department with painless swelling on the right side of face. The swelling extended inferiorly to the upper 1/3 of sternocleidomastoid and the submandibular region, superiorly up to the level of tragal cartilage, and anteriorly within the 3 cm of the angle of mouth. On examination, the swelling was soft, fluctuant and non-tender with no signs of inflammation. Facial nerve function was preserved. The patient had no prior history of infection, trauma or surgery in the region. Ultrasound revealed a multiloculated cystic collection in the right parotid region, approximately 7 into 4 cm. FNAC suggested the benign cystic lesion. Contrast-enhanced MRI showed an ill-defined multiloculated cystic lesion measuring 2 into 6 into 6 cm. Lesion extended superiorly into the right parotid region and infratemporal region, with further spread into the parapharyngeal space, post-styloid prevertebral space, carotid space and posterior vertebral space. The child underwent superficial parotidectomy with careful dissection. Intraoperatively, the cyst was found infiltrating the infratemporal fossa, parapharyngeal and carotid spaces, encasing the internal jugular vein and common carotid artery. Vital nerves including the facial, spinal accessory and greater auricular and descendants hypoglossi were at risk. Post-operatively, the child developed incomplete eye closure due to transient facial nerve paresis, which resolved with conservative treatment over 3 months. Full recovery was achieved. These are the images showing the preoperative photo, the operative and the post-op. CT scan, contrast enhanced CT photo, and the grade 3 facial paresis on day 15, and the complete facial nerve paresis resolution after 3 months. Next is 5-year-old male presented with soft, fluctuant and non-tender swelling in the right parotid region with no signs of inflammation. Facial nerve function was preserved as evident by the complete eye closure and normal oral cavity appearance. Contrast-enhanced MRI revealed a multiloculated cystic lesion in right cheek measuring 5 into 2 into 5 cm. Lesion was located superficial to the right masseter muscle with no solid components or restricted diffusion. Mild wall and locular enhancement was seen on post-contrast imaging without any associated vascular abnormality. Intraoperatively, the cystic lesion was found superficial to the facial nerve and extended anterior to the angle of mouth, adherent to the overlying skin, increasing the risk of injury to all branches of facial nerve during dissection and excision. Surgical approach required careful separation of the lesion from the surrounding facial nerve branches to ensure nerve preservation. So the child was operated using the by superficial parotidectomy. The images showed the intraoperative picture, MRI picture and the post-op picture, which showed the complete eye closure
Last
with
30
the
seconds.
preservation of the facial nerve. A 38-year-old female presented with a gradually enlarging painless swelling in the left preauricular region progressing over 1.5 years. Swelling was firm, mobile and non-tender with no facial nerve involvement or systemic complications. No prior history of trauma, infection or surgery. Ultrasound revealed the hypoechoic lesion, MRI 4 into 3 into 3 cm lesion.
Please conclude, the time's up.
The patient was, it is a case of pleomorphic adenoma which was operated using the superficial parodidectomy. Next case is a 60-year-old male with high-grade mucoepidermoid
Dr.
carcinoma.
Survi, sorry, but the time's up. Please conclude.
In our study, microscopic assisted groups were 5 cases in which in all the cases the facial nerve was preserved. Open conventional group were 15 cases. Transient facial nerve paralysis was seen in 8 cases with House-Brackman grade 2 to 3, recovery in 1 to 3 months with conservative care. Facial nerve sacrifice was seen in 1 patient with grade in the case for high-grade mucoepidermoid carcinoma. No post-op nerve recovery was seen. So microscopic assisted group, they have better cosmetic outcome, faster wound healing, shorter hospital stay. No major complications, no hematoma, no psilocele and no Frey syndrome. Open conventional technique remains the gold standard for malignant tumors, deep lobe or infiltrative tumors, while the microscopic is good for preservation of the facial nerve.
We can have the questions now.
Thank you.
Thank you, Dr. Survi. Moving on to the junior consultant category for paper presentation. First, I'd like to call Dr. Aseem Anand, Department of ENT, MGM.
Afternoon, everyone. I'm Dr. Aseem Anand, Senior Resident in Department of ENT, MGM Medical College. And I'm going to present a paper on Sushruta flap in reconstruction of nasal defect. So this picture has been taken from Sushruta Samhita. It is AI modified picture, which is showing Sushruta doing a nasal surgery. And the quote says, truth like surgery may hurt, but it cures. So it aligns with the theme of surgical intervention for healing. Basal cell carcinoma is derived from non-keratinizing cells originating from basal layer of epidermis, common in whites, that is 65 to 75% of population. Rare in dark-skinned individuals, 1 to 2% of Indians are affected by basal cell carcinoma, of which 1/3 are white population. Risk factors are exposure to solar UV radiation, ionizing radiations, arsenic exposure. This is characterized by slow growth, minimal soft tissue invasion, and high cure rate with surgery. Removal of tumor will lead to tridimensional defect, that is skin, cartilage, and even nasal mucosa. A reconstruction of this defect will be challenge to surgeon. There are many techniques used for reconstruction of these defects, of which Sushruta flap is the oldest one. Guiding principles for flap design and elevation include maintaining an axial pattern whenever possible, utilizing an ipsilateral pedicle, cautious extension of flaps at right angle across forehead, utilizing a reasonable size pedicle, and early subperiosteal dissection. 60-year-old male presented to our OPD with chief complaint of solitary ovoid ulcerated lesion on the dorsum nasi for past 3 years. Patient was farmer by occupation with no history of any ionizing radiation exposure or work in any industrial setup. There was no relevant family history. As we can see on examination, there is this 1.5 centimeter into 1 centimeter lesion. that is ulcerated and has rolled out margins. Incisional biopsy was taken for this lesion, revealed a small geographic lesion composed of small round basaloid cells in proliferation. The cells showed mild anisonucleosis, atypical mitosis, and peripheral palisading consistent with basal cell carcinoma. Under general anesthesia, lesion was removed with 5 mm free margin. After removal of lesion with free margin, we can see a defect, and for reconstruction of this defect, we had used Sushruta flap. Flap template was created by measuring the distance from the defect side to the medial end of upper eyebrow, and same distance was applied from medial end of upper eyebrow to the distal forehead. Pedicle location was approx 1.5 centimeter away from the midline, that is lateral to the midline. Base of the flap was 2 mm wide in order to occupy the pedicle. The tip of flap for initial 1.5 to 2 centimeter is raised in subcutaneous plane with removal of subcutaneous fat and underlying frontalis muscle. This tissue can be safely thinned because the supratrochlear artery is in subcutaneous plane at a level approx 1 centimeter above the brow. Single layer of permanent monofilament suture is used to close the donor site. Open area of flap pedicle is covered with Surgicel to ensure good hemostasis and adequate healing. Patient was regularly examined. Surgicel changed on every 3 to 4 days on raw site of pedicle and looked for color change in graft site. Second stage of operation, that is refreshening of flap, was done on day 21. As we can see, that is the raw area, and we applied Surgicel over the raw area every 3rd to 4th day. And refreshening of the flap was done on 21 day. As we can see on the host side and the defect side, we have removed the flap and sutured. BCC basal cell carcinoma represents 65 to 75% of cutaneous malignancies, 20 to 30% in Asian Indians, 80 to 85% have been located in head and neck region, 15% on the trunk, 2% unusual areas like abdomen. It has 5 subtypes: nodular, superficial, pigmented, basisquamous, and mosaic. Nasal tip amputation was a common punishment in crimes during 700 BC. Medical treatise entitled the Sushruta Samhita describes about the treatment of nasal reconstruction. G.M. Warren brought Sushruta technique to Europe in 1500s via the Arabs and to the United States in 1830s. Kazanjian described supratrochlear and supraorbital arteries as the primary blood supply of the flap in 1930s. That led to significant innovation in its design. Median forehead flap based upon a unilateral supratrochlear artery was designed by Labart. The primary aim of treatment is surgical excision of the tumor. Other are cryosurgery, laser therapy, and immunotherapy. A skin graft can cover superficial defect and has tendency to contract and may not take up properly. Use of Sushruta flap in order to restore the skin cover of the tip of nose after basal cell carcinoma removal leads to excellent outcome. The forehead flap represents the ideal reconstructive choice in many patients and can be safely and reliably performed in patient setting. It is a robust flap with good pedicle vascular supply. This is the result. We did a wide local excision with Sushruta flap reconstruction for basal cell carcinoma nose. Reconstruction was well accepted, maintaining the nasal contour with no any significant morbidity. Hence, it concludes that Sushruta flap should be considered gold standard for nasal reconstruction. These are my references. Thank you for the time. Thank you.
Thank you for your beautiful presentation. Thank you.
Thank you, Dr. Asim, sir.
Now I would like to call Dr. Gunveen Kaur Narula ma'am, Department of ENT, Reuben Hospital, Patna, for her presentation.
A very good afternoon to all of you. I, Dr. Gunveen Kaur Narula, Junior Consultant in Reuben Memorial Hospital, Patna, is standing here to present a case series of parathyroid adenomas. Introduction: parathyroid glands are small, oval-shaped structures found close to the thyroid. Usually they are 4 in number, 2 superior and 2 inferior. The superior glands are usually present posterolateral surface of the middle to the superior thyroid lobe, and inferior glands can vary from thymus to the suprasternal as they descend with the thymus, and they are commonly located in the inferior third of the thyroid gland. A normal parathyroid gland weighs 0.5 gram, microadenomas are 0.1 gram, and giant adenomas are said when the weight is over 3 grams. The disease spectrum of parathyroids includes parathyroid adenomas, parathyroid hyperplasia, and parathyroid carcinomas. The primary hyperparathyroidism is, in a severe case, is characterized with 3 words, that is stones, bones, and groans. Stones refers to urolithiasis, bones refers to osteopenia, and groans refer to the gastric disturbance, that is nausea, vomiting, and unable to digest the food, and constipation. The leading cause of primary hyperparathyroidism are solitary parathyroid adenomas seen in 80 to 85% of cases. Secondary causes include parathyroid hyperplasia, multiple adenoma, and rarely parathyroid cancer. The prevalence is seen in 1 to 7 per 1,000 in general population. Equal incidence to male into female in the age less than 45 years, and ages above 70 years, there is female preponderance. The objective is to present a case series of 3 parathyroid adenomas presenting with different presentations in OPD, discuss the evaluation of a patient with parathyroid adenoma, and explain the management strategies. The first case is a 36-year-old female with complaint of generalized body weakness, unable to walk, and multiple episodes of vomiting and nausea. Her initial blood examination revealed hypercalcemia and hypophosphatemia, which lead us to measure the parathyroid levels, which actually came to be 2,442.2 picogram per ml, which established parathyroid adenoma. All other reports for thyroid were normal. She was suffering from severe anemia. On USG, there was a hypoechoic nodule at the inferior pole of the left lobe of the thyroid gland. CECT showed a hypoechoic lesion present in the left inferior part of the thyroid gland. This patient presented on wheelchair. She was very weak. On her x-rays, we can see that there is a proper saltpeter appearance in the skull part, and we can see on the middle and the index finger that there is convexity in the metaphalanges and a tip-form deformity. My second case is a case of 71-year-old male presented in the OPD with pain in throat, weakness, and unable to eat. His examination revealed increased serum calcium, and PTH came to be 504.8 picogram per ml, and so the patient was diagnosed with hyperparathyroidism. His USG also revealed a hypoechoic nodule, and this patient underwent 99M technician system-based scan, which shows take-up of radio tracers in the left inferior parathyroid even after 2 hours, diagnosing parathyroid adenoma. The third case is a 46-year female presented in the urology department with intermittent right flank pain and recurrent passage of kidney stones. She did not have any palpable neck masses, but on her biochemical investigation, we see a raised serum calcium 11.6, serum phosphate, hypophosphatemia, increased serum PTH levels. There was elevated urine 24-hour urine calcium levels. Her vitamin D was decreased. Her neck ultrasound also showed a hypoechoic lesion in the posterior to the right thyroid lobe, and her scintigraphy showed a right side lower thyroid nodule tricking the tracer, and her KUB, X-ray KUB showing a staghorn calculi. So now we have already seen the clinical history undertaking the biochemical investigation and radiological, the patient had to be managed surgically. So all the 3 patients underwent parathyroidectomy along with intraoperatively parathyroid hormone level measurement prior to adenoma excision and subsequently at 10 and 20 minutes post-excision. Patients were lied in a supine position, transfer incision was given, both the platysma was dissected, superior and inferior flaps were elevated, midlinely strap muscles were retracted, and we could see both the superior and inferior parathyroid, and the parathyroid adenoma appears as a firm reddish brown or tan nodular structure differing from the another parathyroid, and it was removed, preserving the recurrent laryngeal nerve. Before and intraoperatively PTH monitoring was done. This is the result in the first case that on the parathyroid adenoma excision there was a adenoma 2 into 1.5 into 1.5 centimeter weighing 1.8 grams was removed. Preoperatively her parathyroid hormone level was 2172 picogram per liter, but there was seen a marked drop in the parathyroid hormones at 10 minutes, that was 231 within 10 minutes of excision. Preoperative corrected serum calcium was 13.1 milligram per dl, which decreased to 7.2 milligram per dl within 24 hours postoperatively. So this patient landed into a postoperative complication, developed tetany, serum calcium was persistently less than 8 milligram per dl, and this patient was diagnosed with a hungry bone syndrome, for which endocrinologist and medicine opinion was taken, and patient was started on injection calcium gluconate, magnesium and vitamin D supplementation. Her histopathological examination confirmed a well-encapsulated parathyroid adenoma, and she was discharged on the 12th postoperative day. My second and third case went similar surgeries. There was a decreasing trend of parathyroid hormones, but the another 2 patients did not had any postoperative complications, and they were good to go home on the 5th postoperative day. This is an HEP slide showing mainly the chief cells that shows that it is a parathyroid adenoma. This is a similarly. So now I'm coming to the discussion. Primary hyperparathyroidism presents with a wide range of clinical manifestations, including neuromuscular weakness, fatigue, skeletal complications, recurrent nephrolithiasis, and nephrocalcinosis, as well as neuropsychiatric symptoms such as depression, cognitive impairment, and memory loss. Gastrointestinal symptoms like nausea, vomiting, and constipation, along with cardiovascular features such as bradycardia, can also be seen. In the earlier decades, patients of primary hyperparathyroidism often presented with marked symptom of severe hypercalcemia and advanced bone diseases. In some cases, dehydration precipitated a hypercalcemic crisis, characterized by acute elevation in serum calcium levels, leading to abdominal pain, gastrointestinal disturbance, and significant cardiac and renal dysfunction. However, with the widespread adoption of routine biochemical screening, an increasing number of patients are now diagnosed incidentally, often presenting with only mildly elevated calcium levels and subtle or non-specific symptoms. The presence of giant parathyroid adenomas or palpable adenomas are still very rare, and the diagnosis can be made with suspicion in the history, biochemical examination, and identifying on the imaging studies. Dr. Felix Mandel performed the first successful parathyroidectomy in 1925. The primitive technique was bilateral neck exploration, but now it has not been done routinely, and now we are going towards minimum invasive parathyroidectomy, that is focused unilaterally exploration with accurate preoperative localization. Intraoperative parathyroid hormone monitoring is very must. According to Miami criteria, a more than or equivalent to 50% reduction in intraoperative parathyroid hormone from pre-existing baseline within 10 to 20 minutes, signifyingly successful removal of the hyperthyroid parathyroid tissue. Postoperative monitoring of serum calcium and PTH level is very important. So I would like to conclude by saying parathyroid adenomas are the endocrine tumors, remain surgically curable cause of primary hyperparathyroidism. Early recognition, precise localization, and minimum invasive surgery supported by intraoperative parathyroid hormone monitoring offer excellent outcomes. Rare presentations such as giant adenomas and ectopic adenomas further emphasize the need for tailored surgical planning and close postoperative follow-up. These are my references that I have studied with this along my cases. Thank you.
Have you seen any case associated with Men's syndrome?
No, sir. In these cases, they were not associated with. Actually, the men's syndrome, both 1 and 2, are mainly associated with parathyroid hyperplasias. All the cases were parathyroid adenoma, so I could not find any of the correlation with the syndrome.
How you suspect that patient suffering from the parathyroid adenoma?
Sir,
clinically?
Yeah. Sir, when the patient comes with sir, that the patient came on a wheelchair, feeling very weak, unable
Directly
to.
came in ENT OPD or referred from the medicine
Sir, two
department?
patients came to us. One was referred from the urology department. So one which came on a wheelchair was having hypermesis. He was not able to eat, just keep on vomiting whatever we gave. So and having a pain in the throat. So the patient came on the biochemistry evaluation. The calcium was very high. Phosphate was very low, so we suspected it could be a parathyroid adenoma, and we sent the patient serum for parathyroid hormone evaluation, and the result came out to be drastically that it was 100-fold increased. So we went for then USG and then CT scan and system B scans, and then that's the way we diagnosed.
Thank you.
Okay. Thank you.
Thank you, Dr. Gunveen ma'am. Now I would like to call Dr. Monali Shah ma'am, Department of ENT, MGMMC.
Good afternoon, everyone. I'm Dr. Monali from this institute only. I'm today presenting a paper on olfactory assessments in patients undergoing transsphenoidal pituitary surgery with and without superior turbinate excision. Introduction. Olfaction is one of the primitive senses of living beings that is required for enjoying our food as well as to know about the dangers that lie around us. The olfactory epithelium is a pseudostratified columnar neuroepithelium with no submucosa that consists of supporting cells, bipolar olfactory neurons, and dividing basal cells located in the olfactory cleft. Escada et al. Studied the distribution of olfactory epithelium and concluded that the olfactory mucosa occupies the cribriform area and extends to the superior and middle turbinate and in the midline nasal septum in a minimum distance of 12 millimeters and that may exceed 16 millimeters. During transsphenoidal pituitary surgery, the superior turbinate is often excised to gain adequate exposure of the sphenoid sinus and the cellar region, leading us to question whether the excision of superior turbinate will affect the olfaction. How to detect presence of olfactory epithelium in the specimen? The olfactory epithelium can be detected by light microscopy immunohistochemistry. The various IHCs available are olfactory membrane protein, calcium binding protein D28K, neuron specific enolase, growth associated protein 43, protein gene product 9.5. PGP 9.5 is mapped to chromosome 4p14. It specifically labels the neuronal cell body and axon of the central and peripheral neuron system. It is detected using anti-PGP 9.5 antibody and IgG polyclonal antibody that is produced against synthesized peptide from rabbit. The aims and objectives of our study were to compare the pre- and post-operative olfactory function in patients undergoing endoscopic endonasal transsphenoidal pituitary excision with and without superior turbinate excision using pocket smell identification test, and also to identify if there was presence of any olfactory neurons in the excised superior turbinate specimen. The methodology, it was a single-center prospective study conducted from January 2018 to June 2019. A total of 50 patients having various pituitary pathologies like non-functioning pituitary adenoma, acromegaly, pituitary apoplexy were included in the study. The patients were of age 18 to 80 years and with pre-op normal olfactory function without any previous history of nasal surgeries and the revision cases were also excluded. A detailed otolaryngological and neurological examination was conducted. Ophthalmology workup was done, CT scan of the paranasal sinuses and the MRI brain was done for each patient. Written informed consent was taken from each of the patients, and then a pocket smell identification test kit was performed to assess the preoperative olfactory function. This is an MRI film of the patients, of a patient showing pituitary adenoma, sagittal and coronal cuts, showing the pituitary tumor is involving the cellular and supracellular region and also bulging into the sphenoid sinus. This is the pocket smell test card that was used for the study. It is a 3-item scratch and sniff test, forced choice screening test for olfaction that comprises of microencapsulated odorants developed by the Sensonics International. The universal version that was used for this study had 3 smells, that was of mint, paint thinner and peanut. Olfactory assessment was done pre-operatively and then 1 month and 3 months post-operatively. The total of 50 patients were divided into 2 groups of 25 each. In the group A, the superior turbinate was preserved, and in group B, the superior turbinate was excised. All the patients underwent transsphenoidal pituitary excision under general controlled hypotensive anesthesia. And for adequate exposure, in group A, the superior turbinate was lateralized, and group B, the superior turbinate was excised. The excised superior turbinate in group B was sent to the Department of Pathology for HPE staining with PGP 9.5. The PGP 9.5 staining was the IHC staining done using anti-PGP 9.5 antibody. The antiserum is produced against synthesized peptide. It is a polyclonal antibody and is considered to be a specific marker for the neural and non-neuroendocrine cells. A nerve fiber was taken to act as a positive internal control. Results in both the groups, group A and group B, majority of the patients were from the age group 41 to 60 years, and both the groups had equal age distribution with no statistical difference. Similarly, there was no statistical difference in the sex in both the groups. This is the chart showing the olfactory assessment conducted preoperatively and postoperatively in both the groups. In group A, in which the superior turbinate was preserved, preoperatively, all the patients had normal olfaction. At postoperative first month, 3 patients developed anosmia and 1 patient developed hyposmia. On further follow-up at 3 months, those having anosmia, out of the 3 patients, 2 had persistent anosmia and 1 hyposmia improved to hyposmia. The 1 patient having hyposmia improved completely at 3 months post-operatively. In group B, in which the superior turbinate was excised, at 1 month, 2 patients developed anosmia and 4 patients developed hyposmia. At further follow-up at 3 months, the 2 patients having anosmia, there was no improvement. In 4 patients who had hyposmia, 3 improved completely and 1 had persistent hyposmia. This was the immunohistochemistry staining done. Out of the total 25 patients, 39 specimens were obtained of superior turbinate from 21 patients. Neuronal tissue was taken as the positive internal control. The first picture, above picture, shows the positive internal control with IHC staining with PGP 9.5. The first, in below, the first picture shows the negatives control. Out of the 39 samples, only 1 showed positive, sparse positivity, and that was also doubtful. Rest all the specimen, all the 38 specimen did not show any positivity with PGP 9.5. The lowermost and the last picture shows the sparse positivity sample. Discussion. At 1 month post-surgery, olfactory complications were observed in a total of 10 patients. That was about 20% of the patient of our study, with 50% hyposmia and 50% anosmia. At the end of 3 months, out of the 5 patients who had a hyposmia, 80% showed complete gain, while 20% had some partial recovery. On the other hand, those out of the 5 patients who suffered for complete anosmia, only 1 patient showed partial gain of olfactory function at the end of 3 months, and rest 4 patients, that is 80%, were still anosmic at the end of 3 months. This indicated that the olfactory loss was common complication post-surgery, but it gradually improved with time. The gain in olfactory function was expected to be better in patients having hyposmia rather than complete anosmia. The IHC staining done using PGP 9.5 in this study showed only 1 positive specimen out of 39, that is 2.6%. The specimen that was positive, however, did not belong to the patient who had any post-operative olfactory complication. The patient, in fact, did not have any olfactory changes even at 1 month. This is in lieu with the study conducted by Say et al. That showed that there was no correlation between patients developing anosmia post-surgery and positive IHC staining. However, the IHC staining in our study did not identify olfactory neuroepithelium in the superior turbinate, as did by so many other studies like Lane et al., Pinna et al., and Escada et al. Concluding, olfactory change is a significant complication in the endoscopic TSS that occurred in 1 out of every 5 patients in our study. The olfactory function gradually recovered over time in most patients, especially those who suffered from hyposmia at the initial follow-up period. Though excision of superior turbinate increased the risk of olfactory dysfunction in the early postoperative period, the rate of recovery was similar to that of patients in whom the superior turbinate was preserved. Hence, it concluded that the superior turbinectomy is a viable option to gain wider access to sella during pituitary surgery without any additional olfactory complications. The lack of IHC positivity in the excised superior turbinate specimen in our study might indicate that the Indian population lacks olfactory neuroepithelium in the superior turbinate. However, further studies are required to either support or deny this theory. These are my references. Thank you.
Is there any correlation between the Kiros classification and CSF leak and the olfactory function?
Sir, that part is not included in my study, but Kiros classification, higher the Kiros grading, there is more chances of CSF leak. And since the Kiros classification is at the level of cribriform, if we go for a CSF repair, most likely that will lead to higher olfactory dysfunction. Thank you, sir.
Thank you, ma'am. Thank you, everyone. The paper presentation competition is over now. Now I request all of you to proceed for lunch.
Our moderator will be Dr. Alok Bose Majumdar sir. And our presenters will be Dr. Gursimrat Kaur and Dr. Surabhi Gupta.